The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Now let's talk about your central nervous system drug. So this is quite a long part of the pharmacology lecture. So I suggest get some coffee, get some snacks, and let's go right into it, okay? So before we discuss the specific drugs of your central nervous system, it's really important to discuss a few things about how the central nervous system receives and responds to drugs. One of the first most important things to discuss is what we call the blood-brain barrier. So in the early 1800s, or the late 1800s, sorry, anatomists discovered that when they inject colored dye into the bloodstream of animals, they found that all organs would be stained by the color of the dye. So they would find the liver, the lungs, the kidneys would be blue, which is the color of the dye. The one organ that seemed to be spared by the dyeing was the brain. And this is when they started to discover that there must be something preventing things in the bloodstream from entering the central nervous system. And this is where we began to discover the concept of a blood-brain barrier. Now, what is the blood-brain barrier? Look at this image. On the left, we have a peripheral capillary, and on the right, we have a capillary found in your central nervous system. Typically, capillaries found in the peripheries have fenestration, so small sort of gaps in between the cells. And this fenestration allows for pinocytosis, which we remember is sipping, cellular sipping, intercellular cell passage, so intercellular cleft passage, so things can go in between the cells. It also, of course, allows lipid-soluble molecules to come and go as they please. Now, compare it to a CNS capillary, which we can see has tight junctions. There are no fenestrations. There are no little alleys and crooks whereby molecules can pass. Therefore, there is no transcellular passage or intercellular cleft passage. The only thing that can go through are lipid-soluble molecules, or if it is carrier-mediated, meaning there is a specific receptor that is able to carry a substance through the blood-brain barrier. In addition to the tight junctions, we also have astrocyte foot processes that typically cover a capillary in the central nervous system, contributing to the blood-brain barrier. So this means that drugs delivered systemically may not always reach the central nervous system unless they have certain properties like lipophilicity or loving lipids that allow them to come and go as they please. Now let's read this together. So the blood-brain barrier prevents access to the brain by the blood, relatively impermeable again, except to small lipophilic molecules, as is the case pretty much all the time. There are options for active transport for molecules that are not small nor lipophilic, like your glucose and your amino acids. Of course, glucose is a vital molecule for central nervous system function, and your amino acids, for example, your L-dopamine, which we will discuss in the treatment of Parkinson's a little bit later. So we can definitely see that the blood-brain barrier prevents or diminishes access to the brain by circulating blood components and is a substantial obstacle for drug delivery to the central nervous system. There are ways to circumvent it or to bypass it. So one thing is intrathecal administration. So of course, if you inject a drug intrathecally, there is no blood-brain barrier to bypass and it can go straight into the central nervous system. An example of this is intrathecal administration of methotrexate in children with acute lymphoblastic leukemia. This is done prophylactically to remove any possibility of meningeal recurrence of the cancer. So again, if you give it intrathecally, syempre, there's no blood-brain barrier to bypass kasi literally pinasok mo na sa cerebrospinal fluid. Another way in which the blood-brain barrier can be bypassed is during times of inflammation. So remember that during inflammation, we typically have vasodilation, which allows more molecules and more fluids to enter and exit capillaries to respond to the cause of inflammation. So for example, in ischemia and in infection like meningitis, the blood-brain barrier can be more permeable, which is why we can still give penicillin, for example, in patients with meningitis, because it is able to cross the blood-brain barrier due to the inflammation of the meninges. There are also circumventricular organs, which are brain regions where the blood-brain barrier is non-existent or much less prominent. So there are 8 circumventricular organs, but not all of them are important. And I'll discuss the ones that perhaps you should know for the central nervous system anatomy and physiology. But these CVOs allow the brain to respond to changes in the chemical milieu of the body. So these are highlighted over here, but the ones you need to know for the purpose of the boards, I think, are your median eminence and your neurohypothesis. So remember, these are used to regulate and release your pituitary hormones. We have your pineal gland in the back, and this is important for melatonin-related circadian rhythm. And really important, of course, is your area postrema or your CTZ, your chemotactic trigger zone. This is located in the caudal wall of the fourth ventricle in the medulla, and it detects toxins that cause vomiting, your emetogenic toxins, okay? And that's why it's important na wala siyang blood-brain barrier because it has to know right away whenever there is anything toxic in the system that we need to vomit out. So that's why it's a CVO. Next topic to discuss is the concept of central neurotransmitters. So I know this was discussed in physiology, but let's just quickly review it. Remember, neurotransmitters allow communication between neurons taking place mostly at your synapses. It can be fast communication through excitatory or inhibitory postsynaptic potentials, or it can be slower through a process called neuromodulation. So remember that we have a presynaptic terminal with synaptic vesicles inside. They release the contents of their vesicles, which are neurotransmitters. These are then picked up by your postsynaptic cell, which has receptors, of course, for these neurotransmitters, and an action potential is generated, and the specific effect is carried out. There are several central neurotransmitters, but the most important ones to know for the purpose of CNS drugs and for pharmacology is number 1, your glutamate and your aspartate. These are your excitatory neurotransmitters. Sino most common in the central nervous system? It's your glutamate. GABA, glycine, taurine, and B-alanine are your inhibitory neurotransmitters. The 2 most important ones you need to know are your GABA, most common in the brain, and your glycine, most common in your spinal cord. You have your acetylcholine, also found in the central nervous system, mostly found in your interneurons. Dopamine, the predominant catecholamine in the central nervous system, in contrast to the peripheral nervous system where norepinephrine and epinephrine predominate. They play a role not only in motivation and reward, but also in motor control, as we'll discuss a bit later in your Parkinson's drugs. Your histamine is mainly located in the ventral posterior hypothalamus for arousal, important in your sleep-wake cycle, which is why we have sedating antihistamines and non-sedating antihistamines, body temperature, and vascular dynamics. And lastly, of course, your serotonin, which is a diverse neurotransmitter with roles in mood, depression, anxiety, and phobias. So the first topic we'll discuss here is your antidepressants. This is an overview by Katsung. So before we discuss the antidepressants, we first have to discuss the amine hypothesis of mood. This is the hypothesis by which most of your antidepressant drugs are based on. So imagine your brain is like a complex chemical factory, okay? It's constantly producing and regulating various substances called neurotransmitters. So these neurotransmitters, as we know, are like messengers that transmit signals between different neurons. One group of neurotransmitters play a crucial role in regulating our mood, and those are our amines. So your serotonin, norepinephrine, and your dopamine. They are involved in a wide range of brain functions like mood regulation, sleep, appetite, and motivation. So this hypothesis suggests that imbalances or abnormalities in the levels of these amines can lead to mood disorders such as depression and anxiety. For example, if there is a decrease in serotonin, it can lead to mood depression. If there is a functional increase in serotonin, it could lead to mood elevation. The same way that if there's a functional increase in norepinephrine or dopamine, it can also lead to anxiety or psychosis. So it has to be a delicate chemical balance in our brain. When the levels of these amines are just right, you feel emotionally balanced and stable. If there is an imbalance or disruption in the production, release, or reuptake of these neurotransmitters, it can affect your overall mood and overall mental well-being. So this serotonergic dysfunction, therefore, is believed to be central to depressive symptoms, and it therefore forms the basis for most of your treatments of depression. Do note, however, that depression and anxiety is not just a chemical thing. It is, of course, also influenced by things like environment, physical health even. So it's a complex interplay of various factors that contribute to our mood. This image from Katsung pretty much encapsulates everything you need to know about antidepressants. This is it essentially. So just to orient you, we have a noradrenergic neuron, a neuron that is able to release norepinephrine, and a serotonergic neuron, a neuron that is able to release serotonin, and the postsynaptic neuron, which carries out whatever these neurotransmitters wants the body to do. So remember, a noradrenergic neuron will have vesicles containing norepinephrine. It releases it into the synapse. It's received by the receptor, and secondary messages are carried out from here. Once it dissociates from the norepinephrine receptor, it stays in the synapse, and then it is reuptake. It is reuptaken by your norepinephrine reuptake channel. And once it's inside the neuron again, it is degraded by your MAO, or your monoamine oxidase, into inactive metabolites. And the same thing happens with serotonin. Serotonin in the vesicle, released in the synapse, attaches to the receptor, serotonin effects. Detaches from the receptor, it is reuptaken by your SERT, or your serotonin reuptake channel. It is degraded by MAO, monoamine oxidase, into inactive metabolites. And it goes on and on and on and on. Therefore, when we want to increase the level of serotonin or norepinephrine, we can either inhibit the reuptake. So as you can see, the ones highlighted in blue, this slows the clearance of the neurotransmitter. It prevents it from getting degraded and going back into the presynaptic neuron. Therefore, it prolongs the dwelling time in the synapse and should also increase the effects it has on the postsynaptic neuron. We can also give degradation inhibitors. Let's say they're reuptake nga, but we want to slow the clearance of the neurotransmitter by inhibiting its metabolism. Therefore, we give something that inhibits MAO, or your monoamine oxidase inhibitors. And that's pretty much it when it comes to depression therapy. So now let's discuss the specific drugs involved in the treatment of depression. So your SSRIs are must-know drugs in terms of depression. These are your first-line treatment really for major depressive disorder. You have your fluoxetine and paroxetine, so magkatunog, citalopram, escitalopram. You also have your sertraline, which is perhaps the most common SSRI, fluvoxamine, and viltazodone. So again, they inhibit the reuptake of serotonin via inhibiting your SERT, or your serotonin transporter. Like I said, it is a drug of choice for major depressive disorder, but can also be used in other psychiatric conditions like GAD, OCD, PTSD, specifically your sertraline and your paroxetine, PMS, premenstrual dysphoric syndrome, and even eating disorders like bulimia. Fluvoxamine is approved only for OCD, and dapoxetine is used for patients with premature ejaculation. And I'll explain why when I discuss the side effects of SSRIs. It is really important to note that when we start a patient on SSRIs for the first time, we have to initiate follow-up within about a month. And why is that? A lot of patients report that SSRIs, or any treatment for depression, sometimes makes symptoms worse before it gets better. So when someone starts taking an SSRI like Prozac or Zoloft, it sets off a chain reaction in the brain. Initially, these medications stimulate certain receptors called autoreceptors in the raphe nucleus, which, if we remember, is the control center for serotonin production in the brain. Okay, the raphe nucleus. These autoreceptors are specifically called your 5-HT1 and your 5-HT7 receptors. Now, what happens when these autoreceptors are stimulated? They act as kind of a feedback system, signaling to the brain that there's already enough serotonin floating around us. So as a result, the brain actually decreases the release of serotonin initially. It's like the brain saying, okay, we have enough serotonin na pala. Let's take it easy on producing more. So here's where things get a bit tricky. The reduction in serotonin release caused by the autoreceptors can initially make depression symptoms worse because serotonin gets even lower. But eventually, the initial worsening of symptoms is very temporary. As the person continues taking the SSRIs over time, something interesting happens. And that is that these autoreceptors get desensitized. So they no longer produce the negative feedback that initially caused the worsening of the depression symptoms. So in a nutshell, the initial worsening of depression symptoms with SSRIs occurs because of stimulation of autoreceptors in the raphe nucleus and also in serotonergic terminals. However, as we keep giving the SSRIs, these receptors become desensitized and this initial worsening gets better and patients report their mood being a bit more regulated. But it is important to counsel patients that this can happen. Now, what are some side effects of taking your SSRIs? So the side effects essentially result from enhanced serotonergic tone. So remember, these drugs aren't smart enough to just say, I want to increase serotonin in the brain only, period. It will also increase serotonergic tone elsewhere in the body. And it's important to note the most common or the most predominant site of serotonin production is actually in our gut. So, it's not something that is specific to the brain. So therefore, you will also have symptoms systemically. So for the brain symptoms, you will have insomnia, increased anxiety, and irritability. The GI tract will cause nausea, diarrhea, and GI upset. Pretty much all of my patients whom I've started on sertraline or citalopram will report to me, Doc, I was a bit nauseated when I first started it. Another thing is in the spinal cord, when you enhance serotonergic tone there, it actually causes diminished sexual function. So up to 30 to 40% will report this side effect. They will report a loss of libido, so they no longer have the sexual drive. They will report delayed orgasm, which is why, as I said earlier, dapoxetine is used for premature ejaculation. If a man has a problem wherein he is ejaculating too soon, we can give an SSRI because it does cause delayed ejaculation. Okay? It also causes diminished arousal. There is another thing called discontinuation syndrome, which is what patients feel whenever they stop taking an SSRI right away. This is especially noted with your sertraline and your paroxetine. So what are the symptoms of your discontinuation syndrome? You get dizziness and you get paresthesia about 1 to 2 days after stopping the drug. There is one SSRI wherein this really isn't noticeable, and that is your fluoxetine. So why fluoxetine? Fluoxetine has a longer half-life, therefore it stays in your system longer, and so the tapering effect isn't as abrupt. It can also be teratogenic, particularly your paroxetine. Okay, remember paroxetine, it's a class B drug associated with atrial and ventricular septal defects. Therefore, we should avoid it during the first trimester of pregnancy. Another SSRI causing specific side effects is your citalopram, which can cause QT prolongation. So I always do an ECG, a baseline ECG in my patients who are started on citalopram, and then I do a follow-up ECG whenever I check their side effects. One very, very important black box warning, even when it comes to the treatment with SSRIs, is it can cause an increased risk of self-harm and suicide in children and adolescents, okay? So this also came out in the boards previously, which one is not a side effect of SSRIs. And everybody was thinking it can't be risk of self-harm and suicide because, this is an antidepressant. That's crazy that it could actually increase the risk. But that is true. Unfortunately, especially in children and adolescents, the risk of self-harm and suicide can increase, especially in the initial phase of treatment with an SSRI. And again, I explained the mechanism of why things get worse before things get better in one of my earlier slides. So really very, very important to take note of this. Okay, don't forget that. So as I mentioned, SSRIs can cause erectile dysfunction and diminished sexual function. There are other drugs that can also cause the same. And a mnemonic to remember this is a sore penis can't F hard. A sore penis can't F hard. So these are your SSRIs, your opiates, risperidone, ethanol and estrogen, propranolol, spironolactone, finasteride, and your hydrochlorothiazide. Another thing that serotonergic drugs can cause is what we call serotonin syndrome, which is caused by the overstimulation of your 5-HT receptors in the medulla. So it is a triad of CAS, cognitive, autonomic, and somatic effects. So you get cognitive effects like delirium, and in even severe cases, it can go into a coma. Autonomic symptoms like hypertension, tachycardia, diaphoresis, and somatic symptoms like myoclonus, hyperreflexia, and tremor. Now, it doesn't typically happen with just serotonergic drugs alone. It is usually associated with taking both a serotonergic agent and a MAOI. So you're also increasing the release or increasing the amount of time serotonin stays in the synapse, and you're also inhibiting the enzyme that degrades it. Therefore, parang nagmumultiply yung effect ng serotonin. Therefore, whenever let's say a patient is responding decently to citalopram, but they want to switch to a MAOI, you have to wait for 2 weeks before starting a MAOI. You have to give a wash-off period in between the two drugs. And the same thing if the opposite if the opposite order is followed. If you give a MAOI initially, you have to wait for 2 weeks before adding another serotonergic agent. And as usual, ang pa-special na drug natin, which is fluoxetine, is exempt from this rule, again, because of its longer half-life. Because it has a longer half-life, it stays in your system longer. Therefore, it should be discontinued for a longer time as well before starting a monoamine oxidase inhibitor, particularly 4 to 5 weeks. Okay? Now, serotonin syndrome looks very similar to malignant hyperthermia and neuroleptic malignant syndrome. So if you'll notice the symptoms here, which I've highlighted, sobrang magkamukha sila. Fever, tremor, clonus, hyperreflexia, vitals unstable, hypertension, etc., etc. So things that set them apart is first, time of onset. So malignant hyperthermia, within minutes of starting a volatile anesthetic like halothane, you will start to notice these symptoms. Serotonin syndrome takes hours, and again, it is caused not by your anesthetics, but things like SSRIs and MAOIs. If you mix it with TCAs, with MDMA or St. John's wort. And neuroleptic malignant syndrome takes a bit longer, 1 to 3 days, and they are seen with your antipsychotics. Their mechanisms are also different. Malignant hyperthermia results from a massive calcium release from your sarcoplasmic reticulum. Serotonin syndrome is from excess serotonin, and neuroleptic malignant syndrome is from antagonizing dopamine. Okay, so they will all have quite similar supportive therapy. A lot of them will involve cooling, but the first-line treatment for the reversal of these syndromes are different. So dantrolene is used in malignant hyperthermia. Cyproheptadine is used in serotonin syndrome, and diphenhydramine is used in NMS. So I'll discuss MH and NMS a bit later when we discuss anesthetics and also your antipsychotics. Okay. Next, we have your tricyclic antidepressants, and they're named as such because of their structure. They're tricyclic antidepressants. You have your ipramines, so they end in ipramine, in mipramine, clomipramine, desipramine, trimipramine. And you also have your triptylines, amitriptyline, nortriptyline, protriptyline. And you have the ones that are weirdly named, your amoxapine and your desipramine. Desipramine pala also under ipramine, okay? So what do these drugs do? So they inhibit neuronal reuptake of both serotonin and norepinephrine. So similar to an SSRI, pero they have the added benefit of also inhibiting norepinephrine reuptake. So this is one of the oldest antidepressants ever discovered, and they have a very good established efficacy. However, they do have quite serious side effects due to their interaction with the histamine, muscarinic, and alpha receptors. So they have the anti-HAM effects, antihistamine, anti-adrenergic, and anti-muscarinic or anticholinergic effects. So remember, as with all drugs that cause anti-HAM, you get histamine blockade causing sedation and weight gain. You get alpha blockade causing orthostatic hypotension. And you get muscarinic or cholinergic blockade causing your Alice in Wonderland syndrome. Your dry as a bone, mad as a hatter, red as a beet symptoms. Okay? So therefore, we only use tricyclic antidepressants in major depressive disorder that is not responsive to your SSRIs. Again, SSRIs are first line, or your SNRIs. I have also initiated a lot of patients with chronic pain on tricyclic antidepressants because these are essentially neuromodulators, okay? And a lot of chronic pain is not just physical, it's also a mix of psychological and neurological disorders that cause chronic pain. So it has been quite effective in patients with chronic pain. Clomipramine has also been shown to be useful in OCD. Now, what are the side effect profiles that make this so unfavorable na even if it's so effective, hindi siya first line? So besides the anti-HAM, which I discussed earlier, amitriptyline and other tricyclic antidepressants also have quite significant effects on cardiac conduction. Particularly, it has a quinidine-like effect on cardiac conduction, causing significant cardiotoxicity. So it should be used in caution talaga in elderly patients or patients who have had a history of cardiac conditions. And if you overdose on a TCA, there are 3 C's that can happen to you. So you get coma, cardiotoxicity, and convulsions or seizures. Don't forget these 3 C's. So I'll discuss why these things happen. So the cardiovascular effects or the cardiovascular toxicities of TCA is caused by several factors. So I mentioned yung sodium blocking or quinidine-like effect on cardiac conduction, causing sinus tachycardia and prolonged QRS complexes. And it also causes an abnormal QRS morphology on an ECG strip. As you can see here, the QRS morphology is abnormal. Because of its anticholinergic effects, it also causes tachycardia and hypertension, or it can cause hypotension because of its alpha blockade effect. This does not help the already existing cardiotoxicity from a TCA overdose. The seizures or the convulsions, so you get a seizure, and of course you get decreased sweating, remember, dry as a bone because of the Alice in Wonderland symptoms. And both of these things contribute to hyperthermia, and this hyperthermia can then cause rhabdomyolysis and multi-system failure. And these two things, the cardiovascular effects and the seizures, can eventually lead to death or a coma. You can go into VFib, you can go to intractable cardiogenic shock, or you can go into status epilepticus. The treatment for cardiovascular effect or cardiotoxicity, especially when you see QRS changes on the ECG, is to give sodium bicarbonate. We give sodium bicarbonate because number one, remember, it causes a sodium blocking quinidine-like effect. So we have to increase the extracellular sodium concentration in order to counteract this. The sodium bicarbonate also causes a direct pH effect on the fast sodium channels, thereby reversing some of the ECG changes seen in TCA overdose. Your SNRIs act exactly like your TCAs. It's the exact same mechanism. It inhibits both serotonin and norepinephrine uptake. The difference lang is SNRIs have a non-tricyclic structure, but they're essentially the same mechanisms of action. So its uses, again, are also chronic pain, such as in fibromyalgia, and can also be used in menopausal symptoms. So I have given duloxetine in patients with vasomotor menopausal symptoms. Some side effects, venlafaxine in particular, can cause hypertension. It can cause CNS stimulation, as we know, from insomnia, anxiety, and agitation, because we are, again, inhibiting the reuptake of norepinephrine, so we get catecholamine effects. Duloxetine can cause hepatotoxicity, and you can get a withdrawal syndrome, even if you've missed only one dose, okay? And because of these side effect profiles, they're not the first-line drug for treatment of depression, SSRIs, they could be second line, okay? Next, we have your serotonin receptor antagonist. So this is a drug class where the mechanisms are not fully understood yet. All we know is that they modulate and block the 5-HT2 receptor, but we don't understand quite yet why this seems to have an antidepressive and anti-anxiety property. So on one drug class, you have your trazodone, nefazodone, and vortioxetine. So they block 5-HT2 receptors. And again, the mechanism is not entirely understood yet. But what we do know is the 5-HT2A receptor, okay, is the receptor that is activated when you take LSD or your acid. And this is why LSD causes often a hallucinogenic and an anxiogenic effect. And so if you block 5-HT2A, you get the opposite. You get anti-anxiety, antipsychotic, and antidepressive effects. So we're not quite sure why yet, but that is about as far as Katsumi explains it. So what are other uses besides antidepressants? Trazodone can be used in hypnosis, and this is because this does produce quite significant drowsiness in trazodone and nefazodone. In fact, trazodone is now being also used as a sleeping pill in some countries. It's used as a sleep adjunct because it does produce significant drowsiness. Another very important side effect is priapism, especially with trazodone, okay? That's why the mnemonic is trazoboner, okay? Because it can cause priapism, which is prolonged abnormal erection in males. I have seen priapism, and it was from a trazodone overdose as well. So trazoboner, priapism. Nefazodone can cause hepatotoxicity because it is nefarious. Nefazodone, nefarious, causes hepatotoxicity. You have your mirtazapine, which is also an 5-HT2 receptor antagonist, and it also blocks presynaptic alpha-2 adrenoreceptors. Okay, so again, the drug class mechanism is not fully understood. Its uses is, again, for sedation and sleeping aid, quite similar to your trazodone. It does cause antihistamine effects, such as weight gain and marked sedation. And because it has alpha-2 blocking effects, it can also cause things like orthostatic hypotension. Okay, so mirtazapine. Bupropion is a drug that inhibits neuronal reuptake of both dopamine and norepinephrine. So SSRIs inhibit neuronal reuptake of serotonin. SNRI and TCA inhibit neuronal reuptake of serotonin and norepinephrine. And bupropion inhibits reuptake of dopamine and norepinephrine. It's used in addition to being an adjunct as an antidepressant. It is very good in helping patients with smoking cessation, as it has been found to reduce the amount of cravings. It does have side effects. It's quite similar to amphetamine as a stimulant because you're increasing dopamine and you're increasing norepinephrine. You get dry mouth, dizziness, weight loss and agitation, and priapism as well. Okay. Next, we have your monoamine oxidase inhibitors. And as I mentioned, your monoamine oxidase is an enzyme inside your neurons that is able to convert the norepinephrine and serotonin into inactive metabolites. So your MAOIs, or your monoamine oxidase inhibitors, include your isocarboxazid, selegiline, phenelzine, transcyclopramine. They inhibit both MAO-A, which is found peripherally, and MAO-B, which is found in the central nervous system, therefore inhibiting degradation of your norepinephrine, dopamine, etc. Selegiline, in particular, is MAO-B selective, meaning it only inhibits degradation in the central nervous system. And again, as I mentioned when discussing SSRIs, when we give this with serotonergic drugs, it can precipitate serotonin syndrome. This drug can also cause what we call a tyramine crisis or the cheese effect. So ano yung tyramine crisis or cheese effect? Monoamine oxidase breaks down norepinephrine, serotonin, and dopamine, but it also breaks down what we call tyramine, okay? And tyramine has indirect catecholamine-releasing properties. It is able to increase the amount of catecholamines in the system. Therefore, let's say you're taking tyramine, lots and lots of tyramine, like fermented vegetables, aged cheese, wine and beer, coffee and chocolates, and you're also on a MAO-I. You then have inhibited the degradation of your tyramine, and therefore you got lots of tyramine in your system. You have indirect catecholamine releasing, and you get a hypertensive crisis, which is the tyramine crisis or the cheese effect. So that's pretty much everything when it comes to antidepressants. Medyo naaral nyo na lahat ng kailangan yung aralin. And again, you can just look at this figure again to help you understand the mechanisms of action of your antidepressants. So let's answer a few questions. Which side effect is not associated with sertraline? Decreased libido, cotton mouth sensation, akathisia, or suicidal ideation? So the answer here is akathisia. So akathisia is a feeling of restlessness. Okay, it's a profound feeling of restlessness. And we'll discuss this as a side effect of one of your future drugs used in the treatment of psychological disorders. Again, suicidal ideation, yes, that is a known side effect associated with SSRIs, especially in children and young adults. It is a black box warning. Which of the following drugs can cause hypertensive crisis with cerebral hemorrhage and papilledema after eating tyramine-rich foods? So, alin dito ang monoamine oxidase inhibitor? Is it trazodone, selegiline, imipramine, or lithium? So, we know that it is selegiline. That is the MAO-I, or monoamine oxidase inhibitor. Remember that your trazodone is a 5-HT2A receptor antagonist, and your imipramine, remember this, imipramine is one of your tricyclic antidepressants, and lithium is a mood stabilizer. Okay. Next, a 23-year-old woman reports having worsening palpitations since starting a new medication. Her ECG shows a prolonged QT interval of 500 milliseconds. What medication is she likely to be taking? Is it limecycline, sodium valproate, venlafaxine, or your citalopram? So what is your keyword here? It's the prolonged QT interval. So what drug causes that? It is your citalopram. So remember, I've highlighted it here. Citalopram can cause QT prolongation. Therefore, it is good medical practice to get a baseline ECG and an ECG after starting the patient on the drug for the first time. Okay, so that's it for your antidepressants. Okay. Next, let's discuss your antipsychotic agents and your lithium or your mood stabilizer. Okay. So before we discuss that, it's really important to understand the dopamine pathways in the brain. So I'll talk through the four main dopamine pathways in the brain, starting with the nigrostriatal. Okay, so the nigrostriatal zone or the nigrostriatal pathway starts from the zona compacta of your substantia nigra, and it goes to the caudate nucleus and the putamen. And remember that this is important for your motor function. And what is the pathophysiology of Parkinson's? But usually it's a destruction of your substantia nigra, therefore causing decreased dopamine in the nigrostriatal zone. So again, nigrostriatal pathway, important for motor control. We also have your mesocortical or mesocortical pathway. So whenever the pathway starts with meso or meso, it just means that the origin of dopamine is from the midbrain, particularly your VTA or your ventral tegmental area, okay? So your mesocortical pathway regulates mentation and cognitive function in the frontal cortex because it goes from the VTA towards your prefrontal cortex, okay? So executive functions, essentially. Then you have your tuberoinfundibular, which is the pathway coming from the hypothalamus to the pituitary gland, as shown here. And again, we know that dopamine tonically inhibits prolactin release from the pituitary gland, meaning we're always releasing dopamine except when a woman is pregnant, for example, and lactating. And this tonic release of dopamine makes sure that prolactin is not being released when we don't need it. Next, we have your mesolimbic pathway. So meso, again, galing sa VTA or your ventral tegmental area, and it goes towards the limbic system, okay? And this is the area that is important in regulation of mood. It is important in the reward-related cognition, so things like pleasure and positive reinforcement. And this is also indicated, or this is also implicated in the pathophysiology of addiction. You know, this is the pathway of addiction. It is also implicated in aversion-related cognition. So things like fear, you know, aversive feelings are also associated with the mesolimbic pathway. And when it comes to the treatment of schizophrenia and psychosis, there is a hypothesis called the dopamine hypothesis, whereby they think that the positive symptoms of schizophrenia, like your hallucinations and your delusions, is because you have an overactivity of dopamine in your mesolimbic pathway, which again is from the ventral tegmental area going towards the nucleus accumbens in your limbic system. So this excess in dopamine in this area causes positive symptoms, whereby there are also negative symptoms of schizophrenia. Remember, they have a flat affect. They typically have a flat face, a masked facies. And this is thought to be a deficiency in dopamine in your ventral tegmental area going towards the cortex. So there's also mesocortical pathway dysfunction. And that is why we think that schizophrenia is caused by an imbalance in dopamine in both of those pathways. So the increase in dopamine or the excess in dopamine in your mesolimbic pathway causes the positive symptoms of HIDE, hallucinations, illusions, delusions, and excitement. And the relative deficiency of dopamine in your mesocortical pathway is what causes the negative symptoms, your loss of function, anhedonia, decreased emotional expression, impaired concentration, and diminished social engagement. Now, so therefore, typically, the most clinically obvious symptoms of schizophrenia are your HIDE symptoms talaga, di ba? Whenever we think of somebody who is schizophrenic or is suffering from schizophrenia, we don't really think of the negative symptoms. We imagine the positive symptoms. We know that they can hear auditory hallucinations, they can see visual hallucinations, and therefore, typically, this is what we want to try to avoid. And so classically, the treatment for psychosis and for schizophrenia has been to lower dopamine in order to mitigate these positive symptoms. However, we have also found that lowering dopamine causes what we call extrapyramidal symptoms. So these are neurologic side effects that occur from anti-dopaminergic activity to areas outside the pyramidal tract, so your extrapyramidal symptoms. So whenever you think of extrapyramidal symptoms, just think of your basal ganglia, okay? So it affects the basal ganglia. So just remember that basal ganglia is like the strict parent of the cortex. It controls movements and prevents wild, uncoordinated motor function. And it requires a balance of both dopamine and acetylcholine to achieve this control of function. Therefore, if the scales tip, okay, and you are giving somebody an anti-dopaminergic agent, you get wild, uncoordinated movements. You are no longer able to control complex movements. You have no postural control, and things like your reflexes are also affected. So that is why you would get extrapyramidal symptoms like tremors, muscle stiffness, which I'll show you in a separate slide. One thing to also note is that antimuscarinic activity lowers the risk of EPS, which is why in patients who present with EPS syndrome symptoms, we sometimes give an anticholinergic or an antimuscarinic agent. So these are the extrapyramidal symptoms, and I'll go through them one by one. I just wanted to quickly show you what I meant by the mechanism of EPS from the Psychopharmacology Institute. Again, in the nigrostriatal pathway, sorry, this is not nigrostriatal, but this is your substantia nigra going towards your basal ganglia. Oh, nga, so nigrostriatal pathway. Remember that dopaminergic transmission has to be balanced with your cholinergic neurotransmission. If you have decreased dopamine activity because you are giving a D2 antagonist, you get the scales tip in favor of cholinergic neurotransmission, and you get your symptoms of your extrapyramidal syndrome. Okay? So what are examples of extrapyramidal symptoms? So the first one you have to discuss is acute dystonia. So look at the picture on the right. They would present with facial grimacing, involuntary upward eye movement, muscle spasms of the tongue, the face, and the neck and the back, and laryngeal spasms as well. So the time of onset is quite early. When you start an antipsychotic drug, you would expect this within 1 to 5 days, and younger patients are more at risk. So what is the treatment for this? We give an anti-Parkinsonian drug, which is also an anticholinergic drug, like your benztropine. Okay, diba? Park my Benz, benztropine. You also get akathisia, or a feeling of restlessness. So this is a side effect of your antipsychotic drugs. This occurs within 5 to 60 days of treatment. So you get restlessness, trouble standing still, constantly pacing the floor, and the feet are in constant motion, rocking back and forth. So for this, we can give clonazepam, a benzodiazepine, or propranolol. You can also get pseudo-Parkinsonism. Kasi diba, what is Parkinson's disease? Its pathophysiology is involved in lowered dopamine in your nigrostriatal pathway. Therefore, if you're blocking dopamine, you can get Parkinsonian symptoms. So you get bradykinesia, tremors, rigidity, and the shuffling gait, the stoop posture, the pill rolling tremors, quite classic in your Parkinson's disease. So it also occurs within 5 to 30 days, and versus acute dystonia, where young patients are more at risk, the elderly are more at risk with your extrapyramidal Parkinsonian symptoms. So the treatment for this is to reduce the dose of your antipsychotic or to give an anti-Parkinsonian drug like your benztropine. Neuroleptic malignant syndrome, or NMS, I already discussed earlier in the table, comparing serotonin syndrome to malignant hyperthermia to neuroleptic malignant syndrome. Just one thing you need to remember, it is potentially fatal. You must stop the antipsychotic immediately and give dantrolene, a cooling agent. Okay. Another form is tardive dyskinesia, which is orofacial dyskinesia. So it usually looks like this. Parang they start doing odd repetitive motions with their mouth, like chewing, sucking, smacking motion of the lips. So chewing, facial dyskinesia, protrusion, and rolling of the tongue. And the treatment here is to discontinue the antipsychotic and to give valbenazine, which is a VMAT2 inhibitor. Okay, valbenazine, VMAT2 inhibitor. Now, what are the drugs, or what are the classifications of our antipsychotics? So they can be divided into first gen, or typical antipsychotics, and second gen, or atypical antipsychotics. So some references we'll call these your FGAs and your SGAs. So what are key differences? Your first generation antipsychotics act more on your dopamine 2 receptors and quite little on your 5-HT2A receptors, whereas the opposite is true for your second generation antipsychotics. Remember what I said earlier about 5-HT2A receptors when we discussed drugs like your trazodone. They have found that LSD acts on 5-HT2A receptors to cause increased sensation, and it is responsible for the hallucinogenesis of LSD. So that is why blocking the 5-HT2A receptors has been found to also have anti-hallucination effects. So again, FGA, because it acts on the dopamine receptors, it addresses your positive symptoms more effectively, and it's less effective with your negative symptoms. Because the negative symptoms is caused by a deficiency in dopamine in your mesocortical pathway. So if you block dopamine there, you're not really improving the negative symptoms. Versus your SGA, which addresses both positive and negative symptoms. Now, your FGAs can be divided into high potency or low potency drugs. The higher potency drugs have a higher chance of causing EPS because it's blocking dopamine more. It's blocking dopamine in your mesolimbic pathway, so very good for psychosis, but it's also blocking dopamine in your basal ganglia, in your extrapyramidal tract, meaning also very good to cause EPS. The lower potency drugs have a lower chance of causing EPS. However, they have a higher chance of sedation and postural drops. Your second generation antipsychotics naman, all of them will have a lesser propensity to cause EPS. But note I say less and not zero because they still act on D2 receptors, okay? There is no antipsychotic that has zero action on D2 receptors. So even if EPS risk is lower, ang mataas naman na risk in SGAs are your metabolic derangements. So things like hypertension, hyperglycemia, and metabolic syndrome. So if you look at the table on the right, I think this is from Goodman and Gilman, what you can see is that the first generation agents, they have a higher potency towards your D2 receptor. So the numbers here, if they are lower, the higher the potency is, meaning mas konti yung kailangan mong drug in order to achieve the desired effect. So notice that the numbers are very small for second generation antipsychotics when it comes to 5-HT2A, meaning mas potent siya kay 5-HT2A. So compare 0.5 versus 57 of your first generation antipsychotic. But what we can see is all of them will have D2 antagonism. Walang zero dito or walang 1 million dito. Okay? So that's because all antipsychotic drugs will still act on the dopamine 2 receptor, and it's just a matter of determining whether mas potent ba siya on D2 receptors or mas potent with 5-HT2 receptors. Okay. I also just wanted to show you how difficult it is to titrate the dose of your antipsychotics and how common EPS is in patients given antipsychotics. The reason being, D2 occupancy by the drug, meaning D2 inhibition, at 60 to 75% is perceived to be effective for antipsychosis. But the moment you cross 78% onwards, this is when you get EPS. So you have such a narrow gap. This is the gap that you really have to avoid, and you have such a narrow narrow room for titration. Kaya it's so difficult to titrate antipsychotics. So the first generation antipsychotics, remember, the potency is more with D2 versus 5-HT2A. Okay, and very good for positive, not as good for negative syndromes. So we have your low potency and your medium to high potency. So kung low potency, this is your chlorpromazine and your thioridazine. Color theory, chlorpromazine and thioridazine. Okay, so color theory. So this is very useful in schizophrenia and other psychotic disorders, as well as in the manic phase of BPD. It has very high anti-HAM adrenergic affinities, anti-HAM affinities. So remember, anti-H means you get sedation and weight gain. Anti-alpha-1 means you get hypotension and failure of ejaculation. Diba? Point and shoot. Erection is parasympathetic. Ejaculation is sympathetic. Point and shoot. So if you inhibit sympathetic receptors like A1, you get failure of ejaculation. And you get your classic Alice in Wonderland syndrome. So it is a very high risk of anticholinergic side effects, especially with thioridazine. Okay? So remember, it has a lower risk of EPS kasi mas mababa yung potency niya, pero you have higher antimuscarinic effects. And that is also why the EPS risk is a bit lower. Remember that I said whenever you give an antimuscarinic, it actually lowers the risk of EPS. So because of its high M1 affinity, it also causes lower risk of extrapyramidal symptoms. Very important to note are the visual side effects associated with these drugs, specifically corneal deposits for chlorpromazine, so CC, cornea, chlorpromazine, and pigmentary retinopathy resembling retinitis pigmentosa is seen in thioridazine. Okay, so C for cornea, tapos si thioridazine naman ay retinopathy. Okay, take note of that, retinopathy. Next, we have your medium and high potency antipsychotics. So that's your haloperidol, flufenazine, trifloperazine, thiotixine. Buti na lang multiple choice ang boards. The way I remember it is somebody with a halo flew up. So haloperidol, flufenazine up, meaning it's a medium to high potency. One thing to note is haloperidol can also be used in Huntington's and Tourette's syndrome. And some side effects, again, like I said, higher potency FGAs have a higher risk of extrapyramidal symptoms, especially with haloperidol. You get hyperprolactinemia kasi remember, in the tuberoinfundibular pathway, the hypothalamus releases dopamine. This tonically inhibits prolactin. So if you inhibit that tonic inhibition, you get hyperprolactinemia. It has limited blockade of anti-HAM, of your HAM symptoms. So it's not as antimuscarinic as your chlorpromazine or thioridazine. Something to note is haloperidol IM. If you listen to or if you watch medical shows from the US or from the UK, they'll say Haldol stat or Haldol ASAP. So it's an IM tranquilizer often given to psychotic patients or patients with very, very acute delirium who present a danger to themselves or to others. So those are your first generation antipsychotics. Let's now proceed to your second generation antipsychotics. Next, we have your atypical or your second generation antipsychotics, okay? There. Now remember, as I mentioned, it has a greater affinity to 5-HT2A versus your D2 receptors. Remember, 5-HT2A receptors are known to cause neuronal excitation, hallucinations, and fear, and it is primarily responsible for the psychedelic effects of taking drugs like LSD or acid. It also has a lower risk of extrapyramidal symptoms, and it also increases dopaminergic transmission in the nigrostriatal pathway. It also has a lower risk of hyperprolactinemia as compared to your first generation antipsychotics. However, the metabolic side effects is much higher in second generation antipsychotics, pero metabolic side effects are much more favorable in terms of safety compared to your FGAs. Therefore, kapag somebody is diagnosed with schizophrenia, usually first line natin ang SGAs or atypical antipsychotics. So I'll start by discussing the drug that is never first line. Okay, so it's a second generation antipsychotic. It is atypical, but it is never ever used as the first line. And that is your clozapine. We only ever use it for refractory and suicidal schizophrenia. That is because of a very severe adverse effect called agranulocytosis, where your absolute neutrophil count absolutely plummets. Okay, so we never ever use it first line, only in these cases. It also has a high HAM affinity, so antihistamine, anti-alpha-2, and anti-muscarinic activity. It causes also a very high risk of metabolic side effects, causes significant constipation and sialorrhea, but it is not typically associated with EPS. Next, we have your olanzapine, which is another antipsychotic. It is also used in patients with anorexia nervosa, and because one of its most significant side effects is weight gain, okay? Along with quetiapine and aripiprazole, olanzapine produces minimal to no increase in prolactin, and that is because it has very minimal D2 antagonism. It also has a reduced risk of EPS. Ang pinaka-high yield dito, weight gain. Okay, so imagine a big guy with a big stomach, looks like a letter O. Okay, olanzapine and closet. Hindi na kasya yung damit mo sa closet because clozapine and olanzapine have the highest risk of weight gain and metabolic adverse effects. You have quetiapine, which is another antipsychotic, which can also be used in the manic episodes or manic phase of bipolar and can also be used in sleep promotion and maintenance. So because it promotes sedation, its side effects are, of course, somnolence, fatigue, sleep paralysis, and hypnagogic hallucinations. Hypnagogic hallucinations are hallucinations you feel as you are about to sleep. So go to sleep, so hypnagogic hallucinations. They can cause cataracts, priapism, and QT prolongation. So what's that other 5-HT2A antagonist that can cause priapism? The trazodone, one of our antidepressants. They are also the least likely to cause tardive dyskinesia among your atypicals. And one thing to remember is quetiapine. Quiet because it can cause sleep promotion and maintenance, somnolence, fatigue, and sleep paralysis. Next, we have your risperidone and paliperidone, which can also be used in Tourette's. And these are the only approved antipsychotics for schizophrenia in the youth. High yield, note that schizophrenia in the youth, RMP only. So it produces insomnia, which is the opposite of quetiapine, which produces somnolence. And it has very, very marked hyperprolactinemia. So RP, rise prolactin, risperidone, and paliperidone cause very, very marked hyperprolactinemia. And again, it's because dopamine tonically inhibits prolactin. So if you antagonize dopamine, you have increased prolactin, therefore you get symptoms of hyperprolactinemia. Next, you have ziprasidone, okay? One of its major side effects is QT prolongation. This is the antipsychotic with the greatest risk for QT prolongation, and it has the lowest risk of weight gain and metabolic adverse effects. So think of it like a zipper. You can zip up the dress with ziprasidone because you have a lower risk of weight gain versus your olanzapine, or big man, or clozapine. You can't fit in the clothes in your closet because you have gained weight. So again, little or no tendency to cause hyperglycemia, hyper-PRL, or weight gain, but it does cause increased mortality in elderly patients with dementia-related psychosis. Next, let's talk about your aripiprazole, another one of your atypical antipsychotics. Now, its mechanism of action is very unique because it is a partial agonist at your D2 receptor. So, Doc, teka lang, akala ko ba that it was an excess in dopamine that's causing the positive symptoms of schizophrenia? So, why would we give something that's an agonist? Now, the reason is aripiprazole is an agonist, but it only works at 20 to 25% of the expected maximum response of dopamine. So, yes, it will function the same way that dopamine does. But when it occupies a receptor, if dopamine occupies a receptor, it produces 100% of the expected effect. Whenever aripiprazole occupies the same receptor, it only produces 20 to 25% of the expected maximum response. So to understand how aripiprazole works as an antipsychotic agent, let's look at the figure on the right, the graph on the right, okay? So here we can see, let's orient ourselves. The y-axis is the dopamine response, presented as percent of maximum, and your x-axis is your drug concentration. So it increases as we go along the x-axis. Let's look at the purple line, which is your dopamine. So if you give dopamine in isolation, so as you increase the concentration of dopamine that you're giving, you get, of course, up to 100% of the maximum expected response to dopamine because you're giving dopamine. If you give aripiprazole, which is represented by this green line over here, you can see that even as you increase the concentration where you would otherwise expect a 100% response, it plateaus at about 20 to 25%. So this is a 20 to 25% mark. And how does that work in the treatment of schizophrenia? So for example, let's look at this red line first. So this red line is what would happen if you gave somebody dopamine plus haloperidol. So because haloperidol is an antagonist, the more haloperidol you give, you would expect this to go to zero, meaning that the dopamine response goes to zero eventually because you're antagonizing the receptors. Versus if you give dopamine plus aripiprazole, so it doesn't go up to 100% because remember, aripiprazole will occupy some receptors and only produce a 20 to 25% until eventually it tapers down to 20 to 25% effect that we expect in patients who have received aripiprazole. So, okay, that's why even if it's a partial agonist at your D2 receptor, it is still able to produce antipsychotic effects. So it is used in major depressive disorder as well and autism. It has been shown to be able to treat irritability in patients on the spectrum. It also lowers serum prolactin, which is special because all of our antipsychotic agents tend to increase serum prolactin. Pero dahil agonist siya, it contributes to the tonic inhibition of prolactin, which is why we can also use it in women with hyperprolactinemia. It also has low risk of metabolic adverse effects and sedation. In fact, it is the least sedating among your atypical antipsychotics, and it has no atropine-like effects because, as you can see here, it does not have any affinity towards any of your muscarinic receptors. Okay? So this is a quick summary of the side effects of your second-generation antipsychotics, the ones you must not forget. So remember, all of them will have some variation or some extrapyramidal symptoms. All of them except for your ziprasidone and aripiprazole will have hyperprolactinemia. Letter M, risperidone, kasi diba, RP, rise prolactin, very marked prolactinemia. Some of them will have postural hypotension. The weight gain is most prominent with your C, clozapine, and O, olanzapine. O, very, very fat person, okay? Hindi na kasya yung clothes niya sa closet, okay? Weight gain. And hyperlipidemia is also found in those two drugs as well. And agranulocytosis, yung isang side effect that we can absolutely never forget, is found in clozapine, which is why we only ever use it in refractory and suicidal schizophrenia. Okay? Let's go into some practice questions. So which of the following is not an indication to use haloperidol? So acute mania, Tourette syndrome, Huntington disease, or none of the above. So again, as I mentioned earlier, you can actually use it to treat all of these conditions. Therefore, none of the above is the answer. Remember, not an indication. Which of the following drugs is least likely to cause acute dystonia? Fluphenazine, thioridazine, olanzapine, or chlorpromazine? So remember, acute dystonia is one of your EPS. Is it an acute finding in EPS, or is it one of the later stages? From the name itself, it's one of the more acute findings at EPS. In fact, up to 1 to 3 days after starting the drug, you can start to notice acute dystonia. So remember, ano yung mas common to cause extrapyramidal symptoms? First or second generation antipsychotics, diba? First, therefore, si olanzapine, the only SGA here, is least likely to cause acute dystonia. So si flufenazine, is it high or low potency? So remember, it's halo flu up, so high potency along with your haloperidol. And your color theory are low potency, first generation antipsychotics. A young woman was started on thyroidazine for her schizophrenia. Which of the following side effects is she least likely to experience? Is it a postural drop in blood pressure, QT prolongation, excessive salivation, or constipation? So the answer here would be excessive salivation. Why? Remember that your low potency first generation antipsychotics have anticholinergic effects. They would be dry as a bone. They would have reduced secretions. They would not have excessive salivation. Okay. A schizophrenia patient was started on risperidone. The patient complains of feeling more drowsy than usual. This drowsiness can be explained by risperidone's action on H1 receptors, 5-HT or serotonin receptors, alpha-2 adrenergic or dopamine receptors. So remember, if it's drowsiness and if it's weight gain, it's usually your H1 receptors. Kaya you have drowsy antihistamines and non-drowsy antihistamines, diba? So remember, H1 receptors. And don't forget your anti-HAM side effects, okay? All right, so that's it for your antipsychotics. Okay, next we'll discuss your lithium and your mood stabilizers. So lithium is one of the drugs that is considered a very effective treatment of the manic phase of your bipolar disorder. Okay, manic phase. So remember, in bipolar disorder, it's characterized by periods of mania. So these are expansive or irritable moods, hyperactivity, impulsivity. So I had a patient with bipolar disease who sold their house, who gambled their life savings, and the diminished need for sleep. Nobody knows exactly why lithium seems to help. So until now, the exact mechanism of action is still not entirely understood, but we know that it can be used in both acute phases of mania and in prevention of the recurrent manic episodes. So in terms of the mechanism of action, I don't think you should be too stressed about it because, again, nobody really knows for sure. What they do know is it inhibits GSK3 or glycogen synthase kinase 3, which eventually causes a buildup of a protein called beta-catenin. And what beta-catenin does is it facilitates transcription of a variety of proteins, which are important for neuroprotection and neuroplasticity. So far, that's what we know about the mechanism of action of lithium. Lithium, however, is one of the drugs with a very narrow therapeutic index, meaning the difference between the effective dose and the toxic dose is very, very narrow. And therefore, you have a lot of side effects. So the most common side effect is fine tremors. You see this even in therapeutic doses, meaning even if you haven't breached the toxic dose, fine tremors will happen. It also reduces the kidney's ability to concentrate urine, resulting in polyuria and sometimes polydipsia. This is also known as your nephrogenic DI, and this is a common and reversible side effect of lithium therapy. So remember, nephrogenic DI is the kidneys are unable or insensitive towards antidiuretic hormone. Therefore, ihi ka ng ihi, which is unlike your central diabetes insipidus, wherein your pituitary glands are not able to adequately make enough antidiuretic hormone or vasopressin. So since it's nephrogenic, if you give vasopressin, will this help the diabetes insipidus? So remember, basta it's nephrogenic, no, it will not, because it is the kidney's resistance or insensitivity to antidiuretic hormone that causes DI. It can cause sedation and thyroid enlargement as well as hypothyroidism. The hypothyroidism seen in lithium side effects is reversible and non-progressive. So it's not that serious. It only rarely progresses to very florid hypothyroidism. It can cause a metallic taste in the mouth. It can cause edema because of water and salt retention. And this can also cause weight gain. Leukocytosis is also always present in patients treated with lithium. And in pregnant patients who are given lithium, it can cause what we call the Ebstein's anomaly. So we avoid giving lithium, especially during the first trimester. It is also transmitted in breast milk, so up to about 1/3 to 1/2 of the concentration in your serum can be found in a mother's breast milk. So unless absolutely indicated, we try not to place breastfeeding mothers on lithium. And toxicity of lithium, meaning once we've reached the therapeutic dose and we're approaching the toxic dose, will present with things like vomiting and a coarse tremor. So if you'll notice, yung therapeutic side effect is a fine tremor. If it progresses to a coarse tremor, that suggests toxicity. It can also proceed to ataxia, coma, and seizures. One thing also to note is that patients who have what we call a sick sinus syndrome, which is a alternating syndrome of brady and tachycardia. This is an absolute contraindication to taking lithium because the lithium ion can actually further depress the sinus node. Okay. Now, lithium toxicity, the risks of developing it are increased and decreased by certain drugs. So lithium is cleared renally. Okay, so it is renally cleared. Therefore, any drugs that would inhibit the renal clearance of lithium will increase the amount of lithium in the body and will increase the risk of toxicity. So these are your NSAIDs, which decrease renal clearance, your ACEIs, which cause sodium depletion, and your diuretics, which again also decrease renal clearance of lithium. In particular, your thiazide diuretics are quite well known to cause lithium toxicity when given together. Drugs that reduce serum lithium levels by increasing renal excretion, meaning they cause more lithium to be cleared renally, are your caffeine, valproic acid, and your sodium bicarbonate. Now, until maybe the late 1990s, lithium was the universally preferred treatment for bipolar disorder. However, because of its very narrow therapeutic index, other drugs were explored. And now these new drugs are now usually more preferable in the treatment of bipolar disorder, and lithium is slowly falling out of favor. So what are these drugs? So we have atypical antipsychotics, specifically your aripiprazole, olanzapine, quetiapine, and ziprasidone, which all can be used in bipolar disorder. And there are 3 anticonvulsants that we can give, your VLC, valproic acid, lamotrigine, and carbamazepine. What is to note is that only V and C can be used for both acute and maintenance phase, whereas lamotrigine can be used for the maintenance phase only. Okay? So lamotrigine, maintenance phase lang. Okay? So it cannot be used for both acute and maintenance phases. Now question, can we give antidepressants in a patients with bipolar disorder? So the answer here is no, we do not give antidepressants. We do not give SSRIs, SNRIs, or TCAs because these are known to be destabilizing in patients with bipolar disorder, especially your TCAs. They can even precipitate mania. So again, we avoid antidepressants in patients with bipolar disorder. Let's answer a few sample questions. So a 40-year-old male with bipolar disorder is well controlled with lithium. He now presents to the emergency department with a coarse tremor, confusion, and vomiting. He is currently on another drug for an unrelated condition. His lithium levels are super therapeutic. What other drug is he most likely taking? So which of the following drugs will most likely decrease the renal clearance of lithium, thereby increasing the risk for toxicity? Again, that is your NSAIDs. So remember, it's NSAIDs, ACEIs, and diuretics that can increase the risk of toxicity. Next, we move on to your Parkinson's disease drugs. So remember earlier we were talking about your antipsychotic drugs, which results from a excess of dopamine in certain dopaminergic pathways of the brain. In Parkinson's disease, we have degeneration of dopaminergic neurons. So kulang yung dopaminergic neurons in the substantia nigra. And this is a neurodegenerative disease, meaning we've not really found a cure. We've not found a way to stop it or reverse it. It tends to get worse and worse with time. It presents with a classic triad of bradykinesia, so kinesia, movement, brady, slow, very, very slow movements, sometimes even akinesia or no movement at all, resting tremors, and dystonia. You can remember Parkinson's disease is a trap, so there are tremors, rigidity, akinesia, and postural instability. So these patients will characteristically have the stoop posture, the shuffling or the fenestrating gait. They'll have the pale rolling tremors, speech impediments, masked facies, movement difficulties, slowing of mental processes, and it's also associated with dementia. So just a quick pathocorrelate, remember that its hallmark is the loss of pigmented dopaminergic neurons of the SN pars compacta, substantia nigra pars compacta. And under a microscope slide, you will be able to see Lewy bodies, which are aggregated alpha-synuclein inclusions. Okay, so on the left, we have a normal substantia nigra pars compacta, where you can clearly see the dopaminergic neuron, substantia nigra. And on the right, we have the substantia nigra of a patient with dopamine. So you can see that the substantia nigra is definitely lost in this area. So what are the treatment strategies for Parkinson's disease? So again, ang main mechanism of Parkinson's is kulang ang dopamine produced by the substantia nigra. So therefore, to increase the amount of dopamine, we can either give a precursor of dopamine, which is L-dopa or levodopa. We can give agonists, which act directly on your dopamine receptors to mimic dopamine, or we can inhibit dopamine's metabolism so that it increases the amount of time that dopamine stays in the system. So let's start with discussing how to give dopamine precursors. Just to go back, remember, I always like to view the figure as a general overview of the drugs that we're about to study. So to orient yourselves, this is the blood-brain barrier, this is the periphery, this is the brain. So again, like I said, you can give a dopamine precursor like L-dopa, levodopa, which enters the blood-brain barrier through your L-amino acid transporter or LAT. Remember what I said about the blood-brain barrier? It only allows small lipophilic molecules to go through or molecules that have a carrier transport. So LAT, L-amino acid transporter, is able to get L-dopa in. And once it's in, dopamine, it is converted to dopamine via dopa decarboxylase, and it can be degraded or metabolized by your MAOB, monoamine oxidase B, or your catechol O methyltransferase, or a COMT, and that would degrade dopamine and prevent it from helping patients with Parkinson's disease. So therefore, if you inhibit these inhibitors, we can ensure that dopamine stays in the system longer. And dopamine would then act on the dopamine receptors. And we can also give drugs that act directly on dopamine receptors, and these are your dopamine agonists. So let's go through it one by one. Let's start with giving your dopamine precursors. Doc, you might ask, why not just give dopamine straight away? Well, number one, dopamine does not cross the blood-brain barrier. So again, it requires a transporter, and the only transporter available is an L-amino acid transporter. Therefore, it would only allow L-dopa in. Furthermore, if you give dopamine right away, you increase the risk of adverse effects peripherally. So remember, not all of it will go to your central nervous system. A lot of it will go to your gut, and it will cause a lot of GI side effects as well. So that's why we don't give dopamine straight away. So the most effective drug used in the treatment of Parkinson's disease is what we call your levodopa-carbidopa combination, or your Cinemet. So levodopa or L-dopa is the dopamine precursor, whereas carbidopa inhibits the peripheral metabolism via dopa decarboxylase. So if you look at this picture here, we see that dopa decarboxylase typically converts L-dopa into dopamine in the periphery. So carbidopa stops this from happening. So why is it really important that we give carbidopa as well? Without carbidopa, only 1 to 3% of L-dopa actually ends up into the brain unaltered, because it is so extensively metabolized extracerebrally into dopamine. And this also means a lot of peripheral side effects because of the excess dopamine. So therefore, when you give levodopa with carbidopa, the daily dose required of levodopa is actually reduced by 75% because carbidopa increases L-dopa's efficacy. So it is the single most effective agent for Parkinson's. However, it is not without side effects. Again, if you give dopamine, if you promote dopamine in the central nervous system, it can cause hallucinations, just like in schizophrenia, and confusion. It can also result in an on-off phenomenon or a wearing-off phenomenon. It's not really a side effect. It's more of a consequence of constantly taking the drug. And I'll show you why. So the on-off phenomenon, essentially, all patients with Parkinson's will eventually stop reacting to levodopa and carbidopa as well as they used to. So a lot of them will react really, really well in the first 3 to 4 years until eventually the efficacy wears off. So in the on-off phenomenon, nobody really knows 100% why it happens. But what we know is during the dosing of the medication, so let's say you give it, for example, 3 times a day. During the on episodes, Okay, when you give the dosing, the patient's mobility is very, very good. During the off episodes, which is when you're not giving the dosing, they start to have akinesia. Okay, so akinesia, which is pretty much no movement. And in these cases, during off episodes, this is when we start to give apomorphine. Okay, which is a dopamine agonist, and it has been shown to help with the off episodes of on-off phenomenon. So it fluctuates in response. And then we have the wearing off phenomena, which is quite similar, but essentially the longer you treat with levodopa, so about 3 to 4 years, the duration of the benefit becomes extensively shorter. So it becomes shorter and shorter and shorter until it only approaches the half-life of levodopa. So this is about 60 to 90 minutes, and this is also called your wearing off phenomena or end of dose akinesia. Okay. So again, we've discussed the dopamine precursors. What about the dopamine agonists, which are drugs that can be used to directly activate your dopamine receptors? So all dopamine agonists will have varying degrees of dopaminergic side effects because you're giving something that activates the dopamine receptors right away. So remember nausea and vomiting because your chemoreceptor trigger zone or area postrema contains receptors for dopamine, or orthostatic hypotension because dopamine at low doses can cause venous and arterial dilation. So what are your dopamine agonists? We have your ergot alkaloids and your non-ergot alkaloids. So the ergot ones are your bromocriptine, pergolide, and cabergoline. Yan yung three that you have to remember because those are the ones that usually come out in the boards. They are partial agonists at D2 receptors in the brain. So they are used if a patient is unable to tolerate levodopa. And they are also used in hyperprolactinemia because as I always say, dopamine tonically inhibits your PRL or prolactin. Side effects include erythromelalgia, and the ergot side effects include pulmonary infiltrates and cardiac valvular damage. Okay. What about the non-ergot dopamine agonists? So these are your pramipexole and your ropinirole. So pramipexole attacks or attaches to the D2 receptor and ropinirole attaches to the D3 receptor. They can be used in the restless leg syndrome, and it is also used during the off phenomenon of your on-off phenomena. So what are some side effects of the non-ergot dopamine agonists? It's called ICD or impulse control disorder. So remember that dopamine is the rewarding neurotransmitter in the brain. So if you give a dopamine agonist, it increases your risk of things like pathologic gambling, hypersexuality, compulsive eating, and shopping because you are no longer able to control your impulses because you're receiving such massive amounts of the rewarding neurotransmitter in your brain. So remember, pramipexole is D2 and ropinirole is D3. Okay, so how do we remember that pramipexole activates D2 receptors and ropinirole activates D3 receptors? So just remember twins, so two in a pram pushed by their mother Pam. So pramipexole acts on D2. Alternatively, you can remember that P comes before R and 2 comes before 3. So pramipexole affects D2 and ropinirole affects D3. Another thing you can give is apomorphine, which is an agonist at your D2 receptors and an antagonist at your serotonin and alpha adrenoceptors. It is used, as I mentioned earlier, as a rescue treatment for the off periods of Parkinson's disease, but it only gives very temporary relief. Some of the side effects are same as the dopamine agonist I mentioned earlier. One thing that is quite specific to apomorphine is it's very severely emetogenic, meaning most patients will complain of quite severe nausea and vomiting. So the treatment here is trimethylbenzamide. We do not use ondansetron because ondansetron has been associated with a profound hypotension and loss of consciousness when given together with your apomorphine. Because remember, ondansetron is a 5-HT3 antagonist. Apomorphine is also an antagonist at 5-HT. Okay. Trimethylbenzamide naman, which is what we give in severe nausea and vomiting in patients treated with apomorphine, is a D2 antagonist. Lastly, if we don't give dopamine precursors or if we don't want to give a dopamine agonist, we can give drugs that inhibit dopamine's metabolism. So remember, it is metabolized by MAO-B and your COMP. So we can inhibit those enzymes. So starting with your MAO-B inhibitors, I mentioned MAO inhibitors earlier in the antidepressant talk. So these are your selegiline, rasagiline, and safinamide, which are selective to MAO-B. Because remember, MAO-A is found peripherally and MAO-B is found in the central nervous system. So it decreases degradation of dopamine, therefore increasing the response to levodopa and carbidopa. It can be an adjunct for the waning effect treatment to levodopa, and it can be used parang as an add-on to Sinemet for the wearing off and on and off phenomenon. However, be careful, make sure not to give it again with your serotonergic drugs because it can trigger serotonin syndrome. Next, we have your tolcapone and entacapone, which block metabolism by inhibiting COMT, which is catechol O methyltransferase. So it can inhibit COM2 in the periphery. So that's something that both tolcapone and entacapone can do, or they can only inhibit COM2 in the central nervous system, which is something that only the tolcapone does. So entacapone inhibits COM2 only periphery, but tolcapone inhibits both the periphery and the central nervous system of COMT. So again, it is also used as an adjunct to levodopa. These things are very rarely used on their own. So it can cause a side effect of orange urine, and again, its side effects are related to increased levels of L-dopa. Tolcapone has been associated with hepatotoxicity, so even though it is able to act on COMT enzyme in the central nervous system, its use has also fallen out of favor due to its side effect of hepatotoxicity. So as a mnemonic, remember tolcapone inhibits both CNS and peripheral COMT. Entacapone inhibits the peripheral COMT only. Next, we have an antiviral for Parkinson's disease, and this is your amantadine. So amantadine was initially used as in the prophylaxis and treatment of influenza A. However, we stopped using it as an antiviral because the influenza A viruses became more and more resistant to the drug, therefore it was stopped. However, they did find that it enhanced dopaminergic neurotransmission and could be used in very, very early Parkinson's or as an adjunct again. It also has anti-muscarinic effects, which is something you should note about amantadine, and it blocks NMDA glutamate receptors. So what are some side effects of amantadine? So if you look at the photo on the right, it causes livedo reticularis, this reticulated reddish purple appearance, mostly on the dependent extremities, so your lower extremities. It can also cause behavioral changes and peripheral edema. So I know I touched on anti-muscarinic effects and how they interact with dopamine, but I'll show you a slide on what happens with Parkinson's disease and why anti-muscarinic effects also help in the treatment of Parkinson's. This is just a quick mnemonic to remind you of the other drugs that cause livedo reticularis. Remember, AMAN reads FHM and GQ, so amantadine, FHM, GQ, hydroxyurea, minocycline, gemcitabine, and quinidine. So let's discuss anticholinergics for Parkinsonism. Why do we give some antimuscarinic drugs to help with Parkinson's disease? So let's orient ourselves. We have the substantia nigra, which we remember releases dopamine. And here we have the caudate and putamen of your basal ganglia. So remember the basal ganglia, it essentially is the controller of movement. It reins in the movements. Dopamine inhibits the release of GABA. So GABA is what inhibits the movement. Okay, so si dopamine siya yung relaxed parent, and si acetylcholine yung strict parent. So when you give dopamine, you decrease the output of GABA and you allow movement to happen a bit more spontaneously, a bit more wildly, etc. Which is why if you have too much dopamine in your basal ganglia, like in Huntington's disease, for example, you will have hemibalismus, which is the flailing, wild movements of your extremities. You will have the chorea, the dancing movements, and you will have athetosis as well. So that's why if you have too much dopamine, you get these wild movements. If you don't have enough dopamine, wala yung relaxed parent, nasobraan tayo ng strict parent, which is your acetylcholine. It will tell the body to keep on releasing GABA. Go, make more and more GABA, the inhibitory neurotransmitter. Therefore, you get the brady or akinesia seen in Parkinson's disease. Okay? So there should be a balance between your dopamine and your acetylcholine for normal movement. Nothing too wild, nothing too restrained or akinetic. Okay? So that is why whenever we give an antimuscarinic or an anticholinergic drug, it can help in patients who do not have enough dopamine kasi it balances out the acetylcholine dopamine balance in your basal ganglia. Okay? So that is why we have some drugs that are antimuscarinics, which have been shown to be helpful in Parkinson's, like your benztropine and your trihexyphenidyl. So again, they block your muscarinic receptors. They are adjuncts for Parkinson's disease. They can't really be used alone, or if they are only used in very, very early Parkinson's disease. They are typically insufficient for treatment of Parkinson's disease. They can also help with extrapyramidal symptoms caused by your antipsychotics. So because they are anticholinergics, they will have the same side effects of your atropine. Okay? So your mnemonic here is park your benz by the stop sign. So Parkinson's can be treated with benztropine by the stop sign. The stop sign looks like a hexagon, trihexyphenidyl. Okay? Let's do some sample questions. A patient was prescribed selegiline. Which of the following conditions is the patient least likely to have? So which of these conditions has not been shown to be helpful when given, or has not been shown to be treated by selegiline? So we know that it's psychosis and schizophrenia. Remember, selegiline is a monoamine oxidase inhibitor. It will help with depression. It will help with Parkinson's. It has also been shown to help with ADHD. But in patients who are psychotic, such as schizophrenic patients, they already have enough dopamine. By increasing the amount of dopamine they have, we could even worsen their psychosis. Which of the following Parkinsonian drugs act as an agonist at dopamine receptors? Is it your levodopa, carbidopa, selegiline, and tocopone, or your pergolide? So remember, it's your pergolide. It's one of your ergot alkaloids. Kasama niya si bromocriptine. So levodopa, carbidopa is a precursor. Selegiline is a MAO inhibitor, and your entocapone is a COMT inhibitor. So again, one last review before we leave this section. Remember that Parkinson's disease results from a defect or a lack of dopamine in your nigrostriatal pathway. Okay, and so to do that, so to treat Parkinson's disease, we have to either give the precursor, levodopa, which enters this blood-brain barrier via your L-amino acid transporter or LAT, which is then converted via dopa decarboxylase into dopamine. And to increase the efficacy of L-dopa, we give it with carbidopa, which inhibits dopa decarboxylase in the periphery so that we can increase the availability of L-dopa in the brain. Once dopamine is in the central nervous system, it attaches to your dopamine receptors, and to inhibit metabolism of dopamine, we give MAO inhibitors, which are your selegiline and rasagiline, and we give COMT inhibitors, your tolcapone and entacapone. And once the dopamine receptors, once the dopamine attaches to the dopamine receptors, we can also give adjuncts, which are dopamine agonists that act directly on the receptors themselves. So they can be your ergot alkaloids, like your bromocriptine and your pergolide, or they can be your non-ergot alkaloids, your pramipexole, pram-pam twins, D2, or your ropinirole, 3. So P comes before R, 2 comes before 3. And that's it for your drugs in the treatment of Parkinson's disease. Next, let's move on to your sedative hypnotic drugs, which are divided by Katsum as follows. We'll talk about your benzodiazepines, your barbiturates, and your miscellaneous agents. First, let's try to describe or try to define what sedatives and hypnotics mean. So your sedatives can also be called your anxiolytics. Ito yung mga pampakalma natin. So they reduce anxiety and they exert a calming effect. Your hypnotics naman are drugs that produce drowsiness. So sila yung mga pampatulog. They encourage onset and maintenance of your sleep. The two most important sedative hypnotics to take note of are your benzodiazepines and your barbiturates. So we can see on the right that with increasing doses of these drugs, they cause increasing central nervous system sedative effects. So it can start at the lowest dose as sedation, disinhibition, and anxiolysis. And as we increase, we go up to hypnosis, anesthesia, medullary depression presenting as your respiratory depression, until eventually they can lead to a coma and death. The difference between benzodiazepines and your barbiturates, if we can look at the graph on the right, benzodiazepines exhibit what we call a plateauing curve. So there's a ceiling effect, meaning even at increasingly higher doses, we don't necessarily progress into coma or medullary depression, unlike your barbiturates, which exhibits a linear slope. For as long as we keep increasing the dose, we keep increasing the depressive effects on the central nervous system, and it can eventually lead to coma and death. Therefore, the safety profile of benzodiazepines is relatively better compared to your barbiturates. in terms of their mechanisms of action, they both act on the GABA channel, which is an ion channel, specifically a chloride channel. So this channel promotes the influx of chloride into your nervous cells, thereby preventing the propagation of an action potential. Benzodiazepines increase the frequency of the opening of GABA chloride channels, while your barbiturates increase the duration, so they are open for longer. So a way to remember it is barbituration increases barbiduration. Okay, so barbiturates, barbiduration. I just wanted to show you as well the structure of the GABA A receptor, or the ion channel by which or which these drugs act on. So remember that it is a chloride ion channel, and GABA, which is the main inhibitory neurotransmitter of the central nervous system, acts on the alpha-beta interface, so the interface between the alpha and the beta subunit of the channel, while your benzodiazepines bind at the alpha-gamma interface, or the junction between the alpha and the gamma subunits. We can also see that barbiturates have a separate binding site compared to your GABA and your benzodiazepines. Your Z compounds, your zopiclone, zolpidem, and S-zopiclone, also bind at a similar junction between the alpha and the gamma subunits. I also wanted to quickly touch on the GABA B receptor. So while GABA A receptor, as seen here, is an ion channel, GABA B receptor is a GPCR, or your G protein coupled receptor. So this is the site of action of your muscle relaxant baclofen. So we can see the image on the right to orient yourself. This is a cross section of the spinal cord. We have here the neuron from the corticospinal pathway, which we know is the pathway for voluntary movement. We have an inhibitory interneuron within the spinal cord. And this is your motor neuron, which tells the muscle to move. So your baclofen acts on the GABA B channels, both in the corticospinal pathway and in the motor neuron. And the GABA B channels in the corticospinal pathway function to inhibit the release of glutamate. So by inhibiting the release of glutamate, which we know is the main excitatory neurotransmitter in the central nervous system, we inhibit the propagation of an action potential. Similarly, whenever we activate GABA B in the motor neuron, we also inhibit the propagation of an action potential, even if glutamate enters the AMPA channel. Okay, so this is where your baclofen acts, and that is how it works as a muscle relaxant. So your benzodiazepines, as I mentioned, they function by modulating your GABA receptors, your GABA A receptors. So they are not actually agonists per se of the GABA receptors. Instead, they increase the frequency of opening, and they only do so in the presence of GABA. So without the presence of GABA, they're not effective. They have 5 pharmacologic effects. So they produce anxiolysis, so they remove anxiety. They produce sedation and hypnosis. They have anticonvulsant actions. They can also mediate skeletal muscle relaxation the same way that baclofen can. And they produce anterograde amnesia. So what does anterograde mean? It means there is amnesia to events after administering the drug. One thing to note is they do not cause true general anesthesia. So they do not cause the triad of general anesthesia, which is analgesia, amnesia, and also muscle relaxation. Okay. So what are the clinical uses of benzodiazepines? So you do have to know that pretty much all of them can be used interchangeably because they have such a similar drug profile, but there are preferred benzos for specific clinical uses, and I've highlighted the ones that I think are high yield for the boards. So for status epilepticus, lorazepam and diazepam are the preferred benzodiazepines. For alcohol withdrawal, we prefer a long-acting benzodiazepine like your chlordiazepoxide. Remember, patients with alcohol dependence, they have a hyperglutamergic brain, meaning their brain has a lot of glutamate. The reason their brain has a lot of glutamate, or the excitatory neurotransmitter, is they're trying to compensate for the chronic CNS depression that they experience because of such chronic alcoholism. So the moment you withdraw alcohol, your brain isn't used to not having alcohol. Therefore, it is still in the hyperglutamergic state. You get severe anxiety, you get tremors, and in the worst cases, you get withdrawal seizures, which, if not treated, can result in death. So a lot of my patients who are undergoing alcohol withdrawal, we have to give them chlordiazepoxide regularly, and this is to prevent the withdrawal seizure. In benzodiazepine overdose, the intensity and the incidence of the toxicity to the central nervous system increases with age. So your elderly patients are more prone to overdose, and co-administration with ethanol, because we know ethanol is a CNS depressant. Benzodiazepine is also a CNS depressant. So giving them together increases the toxicity and the risk of overdose. So typically, patients who die from a benzodiazepine overdose, most of them didn't overdose on benzos alone. A lot of them also took ethanol, okay? So the clinical presentation includes slurred speech, decreased mental status, respiratory depression. So as I mentioned, benzodiazepine at high doses can cause medullary depression. And we remember that the medulla is important in generating a respiratory drive. Now, respiratory depression is especially serious in patients who already have pre-existing lung conditions like your COPD patients. Remember that your COPD patients already have a baseline decreased hypoxic drive. So if you give a medication like benzos, this can then worsen that respiratory depression, leading to death. So how do we treat benzodiazepine overdose? The antidote is flumazenil. And I'll talk about flumazenil in a separate slide, but I also just wanted to emphasize, because this came out in the last boards, that your benzos have an additive effect with other sedatives or hypnotic drugs. So we try not to give them in combination with any other drug that can cause CNS depression. With ethanol, not only does it amplify the CNS depression, it also actually increases the rate of absorption of your benzos, which is why they are very, very dangerous when they are taken together. Another thing to note is when we take benzodiazepines with valproate or your sodium valproate, which we know is an anticonvulsant, it can trigger a psychotic episode. So I mentioned earlier that flumazenil is the antidote for your benzodiazepine toxicity. What does flumazenil do? It acts as a competitive antagonist at the sites where your benzodiazepines attach. So they also competitively antagonize your Z drugs, your zopiclone, zolpidem, and your S-zopiclone. Flumazenil is only available intravenously, and they are not effective in the treatment of barbiturates, ethanol, opioids, or your tricyclic antidepressants, which is also why barbiturates are thought to be much more dangerous than benzodiazepines, because when you overdose on barbiturates, there is no antidote, versus when you overdose on benzodiazepines, when we do have a commercially available antidote. In the setting of a tricyclic antidepressant overdose, it may precipitate seizures. So remember the 3 C's of TCA overdose: your coma, convulsion, and your cardiotoxicity. So giving flumazenil is definitely not a good idea in TCA overdose, because it can precipitate the seizures that are already known to be a risk factor or already known to be a risk in TCA overdose. So flumazenil has a significantly shorter half-life than your benzodiazepines, which is why we typically give more than 1 dose, meaning when we give 1 dose of flumazenil, its effects wear off quicker than the effects of benzodiazepine. So you have to give a second, a third, or a 4th dose in order to really reverse the toxicity of benzodiazepines. Your benzos can be divided into either short-acting, intermediate-acting, or long-acting benzos. Your short-acting benzodiazepines can be remembered with the mnemonic ATOM. So an atom is very small, and this should hopefully help you remember that the duration of effect of these benzos are quite short. So these are your triazolam, oxazepam, and midazolam. Again, all of their uses are quite interchangeable, meaning you can use one over the other. Siguro what we have to remember about these drugs is that they exhibit rapid tissue redistribution, and that accounts for their very short-acting property. So note, it is not rapid elimination, it's rapid tissue redistribution, meaning the concentration of the drug is quickly redistributed into other tissues of the body, like your fat or your muscle. Therefore, they become inactive, and they are not able to exert their central nervous system effects. Your intermediate-acting benzos are your lorazepam, alprazolam, estazolam, and clonazepam. So alprazolam and clonazepam are used for anxiety and panic disorders. And your lorazepam, as I mentioned earlier, is really important in the treatment of status epilepticus. Si loraz and si diaz, sila dalawa yung useful in the treatment of status ep. Your long-acting benzos, I highlighted the ones that I think are important. Again, your diaz and your chlordiazepoxide. So really must know diazepam is useful in status epilepticus and chlordiazepoxide is useful in alcohol withdrawal. We can also use diazepam in patients who are exhibiting alcohol withdrawal if chlordiazepoxide is not available. One thing to note about these long-acting benzodiazepines is even if they are helpful in patients with insomnia, they actually decrease REM sleep. So they decrease the amount of time that we spend in REM sleep, but they do also shorten sleep latency. So sleep latency is the amount of time that passes between wanting to go to sleep and actually falling asleep. So they do help you fall asleep, but the end product is they decrease your quality of sleep because it decreases the amount of time you spend in REM. Of the long-acting benzodiazepines, chlordiazepoxide has the longest half-life, which is why we prefer it in patients with alcohol withdrawal because we don't have to dose it as frequently. Your barbiturates, as I mentioned, increase the duration of chloride channel opening, whereas your benzos increase frequency, which is why we remember it by saying barbiduration. Barbiturates, barbiduration. So in addition to promoting chloride influx, the question in the boards that came out most recently, wala yung chloride sa options. Another mechanism of action that barbiturates have is that they block glutamate neurotransmission. So glutamate, as we know, is the excitatory neurotransmitter, and it does so via the voltage-activated calcium channel. So if it asks you what other channels it affects besides chloride, you can say the calcium channels. At very high concentrations, barbiturates can directly activate channel opening even in the absence of GABA. So remember with benzodiazepines, they are only allosteric modulators. They cannot exert any CNS depressive effects without the presence of GABA. This is compared to your barbiturates, where if we keep on giving it at very high concentrations, even in the absence of GABA, it can activate your chloride channel opening. So again, it binds to a receptor site that is distinct from your benzoreceptor site. And in small doses, paradoxically, it actually increases reaction to painful stimuli. The side effects of your barbiturates are very similar to the side effects of your benzos. Again, they cause extension of CNS depression. And remember the graph that I showed you, they don't have a ceiling effect, and therefore their CNS depression is typically greater than benzos. The cardiorespiratory depression it causes, even in the absence of ethanol, can be fatal. And remember, we don't have an antidote, unlike with benzos. Barbiturates are also contraindicated in porphyria. So remember, your porphyria or acute intermittent porphyria is a defect in heme synthesis. And the reason it's a defect in heme synthesis is because we typically have reduced amount of enzymes responsible to produce heme. And so there is a buildup of heme precursors like your porphyrinogens. And these porphyrinogens cause the symptoms of porphyria, your abdominal pain, your psychotic episodes, your neuropathy as well, and your port wine-colored urine. When we give barbiturates, we upregulate the enzymes in heme synthesis. So we keep making the precursors for heme synthesis. However, because there is a block in the heme synthesis pathway, we cannot actually convert it into heme. So the buildup of the precursors gets worsened when we give barbiturates, thereby worsening the effects of acute intermittent porphyria. So it is absolutely contraindicated in any patient with porphyria. Barbiturates are also potent CYP450 inducers, and so they have a lot of drug-drug interactions, okay? So I will discuss the important interactions in later slides. So again, this slide just emphasizes why barbiturates are contraindicated in porphyrias. Remember, it's a condition of defective heme synthesis, and it results from a buildup of accumulated porphobilinogen and neuroporphyrin. So if we induce the enzymes responsible for porphyrin synthesis, we increase the substrate accumulation and we worsen the symptoms. Now, what are some common clinical uses of barbiturates? So in addition to helping with insomnia and pre-op sedation, which is true for pretty much all of these, I've just highlighted the special ones, the ones that are different, and maybe these are the ones you need to memorize. So phenobarbital is useful for status epilepticus and also useful for hyperbilirubinemia. So why is it useful for hyperbilirubinemia, especially in the context of your Gilbert or type 2 Crigler-Najjar syndrome? Remember, the Gilbert syndrome is a mild deficiency of your UDP-GT enzyme in the liver, which helps in conjugating your bilirubin. Type 2 Crigler-Najjar is a slightly more severe version of Gilbert. So by inducing the enzymes responsible for conjugation of your bilirubin via the action of phenobarbital, we actually help with the hyperbilirubinemia seen in these conditions. The phenobarbital is also your drug of choice for neonatal seizures. So the way we remember it is phenobabital because it's the drug of choice for neonatal seizures. Primidone, in addition to helping with seizures, is used in essential tremors. And thiopental, in particular, is very, very rapidly redistributed to your skeletal muscle and adipose tissue because of how lipid soluble it is, which is why we like using it in induction of anesthesia, because it acts quickly and it also wears off quickly. So there is reduced amount of time post-operatively that the patient remains unconscious. So we've discussed your benzos, we've discussed your barbiturates. Let's now discuss your miscellaneous agents, like your newer sedative hypnotic drugs. First, I'll discuss the Z drugs. So this should remind you that they help with sleep. So their names also always contain a Z. So it's zolpidem, zalepron, and ezopiclone. So they bind to your GABA A receptors as shown here. They act similarly to your benzos, but they don't have the same anticonvulsant, anti-anxiety, or muscle relaxant properties. They simply help with sleep. So they are very good for use in insomnia and sleep disorders, especially because they have a much safer side effect profile. Because they don't have the same anti-anxiety and muscle relaxant properties, it is also much less likely that patients become addicted to these medications. So we really prefer the Z drugs whenever we have a patient who presents with insomnia, especially if the patient is elderly, because of the safer side effect profile. We also have your melatonin analog. So from the name rameltion, melatonin analog. Remember that melatonin rises and falls in tune with our circadian rhythm, and the highest levels occur in the evening before sleep. So by giving rameltion, we help with a surge of melatonin before sleeping. So it is very well tolerated, it typically doesn't develop tolerance, and it does not impair next day cognitive function. With your benzodiazepines and your barbiturates, whenever we give it for patients with insomnia, some of them will complain of next day cognitive function because the CNS depression lasts until they wake up the next day. With rameltion, that is not the case. Buspirone is a partial serotonin agonist, particularly at your 5-HT1A receptor. So it also produces anxiolysis with minimal central nervous system depression and minimal muscle relaxation. It is metabolized by your CYP enzyme, so therefore the levels can be affected by CYP inducers and inhibitors. One thing to note about buspirone is it is very well tolerated and it is safe in pregnancy. Okay, so buspirone pwede pang buntis, safe in pregnancy. So let's do a few practice questions. Which of the drugs among the following short acting? So is it diazepam, chlordiazepoxide, alprazolam, or midazolam? So alin dito ang shortest acting? Remember the mnemonic atom. So it's your M, midazolam, along with triazolam and oxazepam. Si alprazolam, wag malito kasi it starts with the letter A. This is actually intermediate acting. The use of benzos is associated with the following side effects in the elderly except, so the answer here is letter B, hypertensive crises. So we know that benzos are sedating, so yes, they can increase the risk of falls. Yes, they can cause psychomotor impairment and they can cause daytime sedation. They would not cause hypertensive crises. If anything, they might even lower the blood pressure. Gertrude, a 91-year-old patient on your ward, says she struggles to fall asleep because of the Q1 monits being done to the patient next to her. What drug can you safely give her to aid her sleep? So she's 91 years old, she's elderly, and she needs a sleep adjunct. So in this population, we would give your Z drugs or your zolpidem, which if we remember has a safer side effect profile. We certainly wouldn't be giving barbiturates to somebody 91 years old for sleep kasi baka mapatay natin si Lola. Thiopental and secobarbital, we definitely wouldn't be giving that. And chlordiazepoxide is a bit more long-acting, so it wouldn't quite help as much with induction of sleep. And also the side effect profile isn't as favorable compared to your zolpidem. Next, we'll discuss your alcohols, alcohol abuse, and alcohol toxicity, starting with your ethanol, which is the drinking alcohol. So I'll talk about how ethanol is metabolized in the body. So ethanol, via the action of alcohol dehydrogenase, is metabolized into your acetaldehyde. So acetaldehyde is toxic, and this is the cause of the hangover effects after a night of drinking. So they can cause headaches, nausea, vomiting, redness of the skin, etc. Aldehyde dehydrogenase detoxifies your acetaldehyde into acetate. So Asians in particular, some of them will have a deficiency of the aldehyde dehydrogenase. Therefore, they experience a much higher buildup of acetaldehyde responsible for what we call the Asian flush, meaning they also have a very, very low tolerance to high levels of alcohol because they are not able to detoxify acetaldehyde as quickly as the rest of the population. There are several chronic effects of alcohol, and I'll discuss perhaps the most common and the most pertinent for the boards. So liver disease, we already know that alcohol has very, very bad effects on our liver because the liver is the main detoxifier of ethanol. The most common complication can stem from or can span from either reversible fatty liver or hepatic steatosis to cirrhosis and eventually liver failure requiring liver transplantation. The most common nervous system effects is your peripheral neuropathy. So they can present with symptoms like tingling or burning sensation in their arms and their feet. It is teratogenic, which is why pregnant patients are highly discouraged from drinking alcohol. They can cause fetal alcohol syndrome, which presents with a triad of mental retardation, microcephaly or a small brain, and underdevelopment of your midface region. They have also been found to increase the risk of breast cancer in women. They found that any amount of alcohol intake, unfortunately, does present with an increased risk of developing breast cancer. They also increase the risk of developing gastrointestinal cancers like your gastric cancer, esophageal cancer, and colorectal cancer. In addition to these systemic effects of ethanol, we also have two syndromes that I want you guys to know about. One is your Wernicke-Korsakoff syndrome, and one is your delirium tremens or your DTs, okay? Wernicke-Korsakoff syndrome results from chronic alcohol excess, but it's not enough to be a chronic alcoholic. You also need to present with thiamine deficiency. Now, the major cause for thiamine deficiency in alcoholism is actually nutritional. Chronic alcoholics tend to have very poor oral intake of nutritious food, and the chronic inflammation of the gastrointestinal tract from alcoholism also causes malabsorption of your vitamins like thiamine. Furthermore, thiamine needs to be converted to its active form, which is thiamine diphosphate, via an enzyme called thiamine diphosphokinase. And this step is inhibited by alcohol. So not only are you not taking enough thiamine, even when you do take in thiamine, your gut isn't absorbing it properly. And even when your gut is able to absorb it properly, alcohol inhibits the step that activates this thiamine. Increased breakdown of alcohol. So when you take a lot of alcohol, it also requires an enzyme called transketolase, and transketolase is thiamine dependent. So it's using up what little thiamine alcoholics have. So how does Wernicke's encephalopathy present? So it's a triad of confusion, ophthalmoplegia, and ataxia. And it's sort of like a spectrum with Korsakoff syndrome. They typically will start with Wernicke's encephalopathy, and then they develop Korsakoff syndrome, which will show irreversible memory loss, confabulation, and personality change. So what is confabulation? This is nonsensical making up of stories, but the alcoholic in question will 100% believe what they're saying. So they think what they're saying makes absolute complete sense, but they could be saying something like, my mother ate the shoelace of a homeless person on the street, when they meant to say, can you please give me a spoon and fork? But in their mind, they're saying, can you please give me a spoon and fork? So the treatment for Wernicke-Korsakoff syndrome is to give thiamine and IV dextrose. However, we have to give thiamine before glucose. And why is that? Remember, when we process glucose, the glucose undergoes glycolysis. And for glucose to be converted into energy, ATP, we require the use of several coenzymes and cofactors, one of which is thiamine. So if we give glucose first, the process of glycolysis will keep using thiamine. Ubos na nga yung thiamine natin. So kailangan mauna si thiamine bago magbigay ng glucose. Next, we have your delirium tremens, which is a feature of alcohol withdrawal. So ano yung usual question stems sa delirium tremens? It will typically be a chronic alcoholic who is admitted into the hospital for, say, a surgery. And then day 3 or day 4 of their hospital admission, they start to present with tremors and they start to tell you that they're having hallucinations. This is delirium tremens because they cannot access alcohol whilst they're in the hospital. So the treatment for this is also benzodiazepines, like I said, your chlordiazepoxide, which is important in inhibiting the highly glutamatergic state of chronic alcoholics, especially when we withdraw their dependence on alcohol. So how do we manage chronic alcoholism? So we know that alcoholism is a disease. They do sometimes need medications to help them overcome this disease. So there are 2 ways that we can treat chronic alcoholism. We can either deter the drinker by giving them something that will make the side effects of alcohol so terrible they will never want to drink again. Or we can give something that will reduce the feelings of cravings or reduce the feelings of reward that they feel from drinking alcohol, which perhaps may be the more humane option of the 2. So for your deterrent, we have disulfiram. So it's easy to remember that this is the deterrent because it's the only one that starts with letter D. So disulfiram deterrent. So what it does is it inhibits aldehyde dehydrogenase, which is your ALDH. We remember that aldehyde dehydrogenase detoxifies your acetaldehyde. And this is what is deficient in a lot of Asians, hence the Asian flush. So by giving a deterrent or by giving disulfiram, we inhibit ALDH. So acetaldehyde skyrockets after drinking. It actually increases acetaldehyde by 5 to 10% more than when drinking alcohol alone. So people who take disulfiram and then drink alcohol will have really severe hangover symptoms right after drinking. And this will hopefully deter them from drinking even more. Your naltrexone and your acamprosate naman are drugs that reduce the feelings of reward and the feelings of craving. So naltrexone works as a mu-opioid receptor antagonist. So it reduces drinking by making the feeling of reward less potent and also decreases the amount of cravings. It is available as a monthly depot injection. It is very long-acting. However, it is contraindicated in liver failure. So unfortunately, if you're a chronic alcoholic who has developed liver failure, this drug is not an appropriate choice. Acamprosate naman blocks the hyperglutamatergic state of alcoholic brain, also causing the decreased feeling of need for alcohol. This will theoretically decrease drinking frequency and also reduce the amount of relapses for chronic alcoholics who were able to become sober. The next alcohol to discuss is methanol or your wood alcohol. So methanol is degraded into formaldehyde also by the action of alcohol dehydrogenase. And formaldehyde is converted into formic acid, which is toxic via the action of your aldehyde dehydrogenase. So if you can see, same lang yung enzymes na ginagamit sa ethanol. So formic acid is the toxic substrate, and I'll explain its effects in the next slide. But first, I also wanted to discuss ethylene glycol or antifreeze, just to show you na magkapareho lang talaga yung enzymes na ginagamit. So ethylene glycol, again, via the action of alcohol dehydrogenase, is converted into glycoaldehyde, and via ALDH is converted into glycolic acid, which can then be converted into oxalic acid, which is the toxic substrate again, or some of it can be converted into formic acid, which is the toxic substrate produced in methanol metabolism as well. So what do methanol poisoning and ethylene glycol poisoning present as? Si methanol poisoning, it will typically present with visual dysfunction, kaya tinatawag na gin bulag, okay? And methanol poisoning is present especially if patients or if people try to drink homemade alcohol, so they don't have any way of determining what percent is ethanol and what percent is toxic methanol. Other ways by which patients can present with methanol poisoning is if they drink windshield cleaners or commercial solvents and photocopier toners. I don't know why patients might do that, but if they do, they can present with methanol poisoning. So in addition to the visual dysfunction, they also cause severe acidosis due to the buildup of your formic acid And again, the visual dysfunction is via retinal damage. Your ethylene glycol naman, again, it forms oxalic acid, and this is typically an industrial exposure to ethylene glycol, so either by inhalation or by skin absorption, or through suicide attempts, like by drinking anti-freeze products. So because it causes a buildup of your oxalic acid, it can cause severe acidosis and renal damage. So the treatment for methanol and ethylene glycol poisoning in the past used to be to give ethanol or drinking alcohol. So I remember there was in PGH a time na may nag-barangay party, may nag-serve ng homemade lambanog, and then a lot of the patients started presenting with visual dysfunction or signs of methanol poisoning. So yung ginawa ng mga residents sa A&E or sa ER were to give people shots of alcohol or drinking alcohol. And the reason ethanol works as a treatment is because it is a preferred substrate for alcohol dehydrogenase. So if we look at the figure on the left, alcohol dehydrogenase, instead of converting ethylene glycol into the toxic oxalic acid and methanol into the toxic formic acid, because ethanol is the preferred substrate, it will act on ethanol instead. However, we know that giving a toxin in order to prevent the toxicity of methanol and ethylene glycol might not be the best idea. And so we came up with a drug called fomepizole. Without the CNS depressant effects of alcohol, it is able to inhibit alcohol dehydrogenase, thereby inhibiting the metabolism of these alcohols into their toxic substrates. So again, ethanol used to be first line, but now we use fomepizole. So just a quick question, just to test your understanding of the preceding topics. A chronic alcoholic is admitted urgently for an XLAP following a diagnosis of ruptured appendicitis. On day 4 of admission, he becomes agitated, unstable, and complains of spiders crawling up his entire body. What drug needs to be given urgently? So what is this patient presenting with? Agitation and hallucinations after day 4 of being admitted in the hospital. This is the classic feature of your delirium tremens. And the treatment for delirium tremens is a benzodiazepine. So letter D, specifically if you were to be asked which benzo, our benzo of choice would be chlordiazepoxide. Next, let's discuss your anti-seizure drugs, which are divided as follows, and we'll go through them one by one. First, we'll discuss epileptogenesis. So how does epilepsy or how do seizures occur? Essentially, they occur either because your inhibitory synaptic activity is reduced or your excitatory synaptic activity is enhanced. So the way to think about anti-epileptic drugs is we either increase this inhibitory synaptic activity or we reduce the excitatory synaptic activity. So the mechanism of action of these anti-seizure drugs fall under 3 general umbrellas or 3 general categories. So the first one is via modification of ionic conduction. So we will either modify the conduction of sodium, or in the minority of cases, we will modify the conduction of calcium. And we can also modify presynaptic transmitter release via modifying SV2A. We can also enhance GABAergic transmission, so enhance the inhibitory neurotransmitter, or we can cause diminution of glutamergic transmission, which is the excitatory transmission. So the drugs that enhance sodium channel inactivation do so by prolonging the inactivation of sodium channels. So remember, we have an inactivation gate that closes your sodium channels, preventing influx of sodium, preventing depolarization, thereby preventing propagation of an action potential. So the end result is we reduce the ability of your neurons to fire at high frequencies, which is the case in seizures and epilepsy. So what are the drugs that cause sodium channel inactivation? The first one I'll discuss is your phenytoin and its water-soluble version, fosphenytoin. So what are their uses? Okay, so this is a broad-spectrum drug. It can be used for generalized tonic-clonic seizures and also focal seizures. So yun ang ibig sabihin ng broad spectrum. It can be used in GTC or your grand mal seizures, and your focal seizures or what was previously known as your partial seizures. Phenytoin is quite a toxic drug, though, and one of the early manifestations of phenytoin toxicity is via nystagmus. It also presents with diplopia and ataxia. So phenytoin has quite a lot of side effects, and you can remember it with the mnemonic phenytoin. So each letter has a meaning. So P is for P450 induction. It is an inducer of your CYP450 enzymes. In fact, most of your anti-epileptic drugs are inducers except for your sodium valproate, which is a CYP450 inhibitor. It also can cause hirsutism, enlarged gums or gingival hyperplasia, nystagmus, yellow-brown skin, teratogenicity in the form of fetal Heidentoin syndrome, osteopenia, inhibited folate absorption, and neuropathy. So the fetal Heidentoin syndrome, as you can see on the left, this is a classic presentation of fetal Heidentoin syndrome. They will have the craniofacial features of an upturned nose, mid-facial hypoplasia, and a really long upper lip, as well as a thin vermilion border. They will also have neurodevelopmental delay, and a high yield associated with fetal Heidentoin syndrome is nail hypoplasia. So they will have underdeveloped nails, and some of them can also have hirsutism. Another thing to note about phenytoin is that metabolism is non-linear. So as it approaches higher doses, elimination becomes zero order. So again, what is zero order elimination? Remember, first order elimination is the rate of elimination is dependent on the concentration of the drug. In zero order elimination, the rate of elimination is independent on the concentration of the drug. So the gingival hyperplasia is a very high yield side effect. And in addition to your phenytoin, what are the other drugs that can cause gingival hyperplasia? Remember, your CCBs, particularly your dihydropyridine CCBs, can cause hyperplasia. And your calcineurin inhibitor, your cyclosporin, which I discussed in the immune modulator section, can also cause gingival hyperplasia. So lahat sila C, CCB, calcineurin inhibitor, and convulsant anti-phenytoin. Okay, the next sodium channel inactivator anti-epileptic drug is your carbamazepine. So in addition to its effects on the sodium channel, it also decreases glutamate release. Now, carbamazepine, in addition to being an anti-epileptic drug, is your drug of choice for trigeminal neuralgia. Okay, so the very, very painful condition affecting the distribution of your trigeminal nerve. It is the drug of choice. Now, unfortunately, one of the side effects that is highly associated with carbamazepine is your Stevens-Johnson syndrome, which is a life-threatening condition affecting the skin and the mucosal layer. Remember, if it affects less than 10% of your total body surface area, it is SJS, whereas higher percentages, we call that TEN, or toxic epidermal necrolysis. Now, SJS is associated with carbamazepine, but it is quite rare. The most common idiosyncratic reaction with carbamazepine is just an erythematous rash, as seen in this patient on the right. Diplopia and ataxia can also occur, and it is the most common neurological side effect, just like in phenytoin. Blood dyscrasias can also occur, such as aplastic anemia and agranulocytosis, both of which are idiosyncratic reactions, meaning they're not dose-dependent. They can just happen sometimes. They are teratogenic. They can cause both spina bifida and craniofacial anomalies. And carbamazepine is a potent CYP450 inducer. So as I mentioned, most anti-epileptic drugs are inducers, except for sodium valproate, which is a CYP450 inhibitor. So this is just a photo of a patient with Stevens-Johnson syndrome because of carbamazepine. So it's often the running joke in medicine that Stevens-Johnson syndrome is the only way to get a dermatologist to come into the hospital on a weekend. Okay. Other drugs that cause sodium channel inactivation is your valproic acid or your valproate. So in addition to the sodium channel blocking, it also blocks NMDA, and it also increases GABA levels. It is broad spectrum, meaning it can be used in both generalized tonic-clonic, absence, and focal seizures. It does cause a lot of GI upset as a side effect, and really important is that it causes weight gain. Okay, valproic acid causes weight gain. So a med student who rotated with me once said the way she remembers it is valproate increases your weight. It is also a teratogen. If you'll notice, it seems to be that most anti-epileptic drugs can be teratogenic. And it typically, or is very known to cause neural tube defects, specifically your spina bifida. So kanina si carbamazepine was spinal or neural tube defects plus craniofacial anomalies. Si valproic acid, spina bifida. So sodium valproate is actually thought to be one of the most teratogenic anti-epileptic drugs. So as much as possible, we avoid placing females who are premenopausal on valproic acid because of how highly teratogenic it is. And like I keep on emphasizing, it is a CYP450 inhibitor versus all of your or most of your other anti-epileptic drugs, which are CYP450 inducers. Let's discuss your lamotrigine. So in addition to blocking the sodium channels, they can also block your calcium channels and decrease glutamate transmission. Niacinamide, on the other hand, only blocks sodium channels. So si niacinamide hindi masyado lumalabas, it's more si lamotrigine na lumalabas. So this drug is really the drug of choice for generalized tonic-clonic seizures, according to your Harrisons. It can also be used in absence seizures and in bipolar disorder. So it does also still have side effects like dizziness and ataxia, and can still increase the risk of SJS or 10, pero not as much as carbamazepine does. Lamotrigine can also be used as prophylaxis for bipolar disorder. Please correct your handout. So it should say may not be used, okay? May not be used for the acute manic phase. So remember, only valproic acid and carbamazepine can be used for the acute manic phase, whereas lamotrigine, in terms of your bipolar disorder, it can only be used as prophylaxis. Next, we have your topiramate. So topiramate is the drug with the greatest number of mechanisms of actions, the anti-seizure drug with the greatest numbers of MOA. So this was also asked in one of the previous board exams. Do take note of that. So it has multiple actions on synaptic function. So it acts not just on the sodium channel, it also acts on the potassium channel, calcium channel, GABA channel, the AMPA glutamate channel, and also it is an inhibitor of carbonic anhydrase. So remember, carbonic anhydrase is an important enzyme also found in the kidneys, responsible or partly responsible for the acid-base balance that we have in our body. And we know that with any carbonic anhydrase inhibitor, we have an increased risk of urolithiasis, or the development of stones in your urinary tract. So because of its weak carbonic anhydrase inhibitor effect, it has an increased risk of urolithiasis. Another side effect that is quite specific for topiramate, though I know I mentioned it in previous drugs, siguro if they were to ask which drug is most likely to cause these, you should answer topiramate. It's sleepiness, cognitive slowing, and confusion, okay? In addition to its uses for generalized tonic-clonic seizures and absence seizures, it is also useful in Lennox-Gastaut syndrome and West syndrome, which we know are seizure types or epilepsy syndromes seen in neonates and in children. So Lennox-Gastaut and West syndrome. And again, don't forget, anti-seizure drug with the greatest number of mechanisms of action. Now, I mentioned that all the previous drugs I mentioned act mainly on the sodium channel. We do have one drug that acts pretty exclusively on your calcium channel, and that is your ethosuximide. So this is a really important drug to remember because it is the drug of choice for your absence seizures. So remember, what do absence seizures present as? They don't look like a grand mal seizure where you have uncontrolled jerking, rhythmic jerking of your upper and lower extremities. You get tongue biting, you get loss of control of your bladder and your bowel, you get upward rolling of eyes. With absence seizures, you just blank, okay? So typically patients will stare into space. They might have some lip smacking or some automatisms, but absence seizures present very differently. And ethosuximide is the drug of choice. They act as a anti-epileptic drug by blocking the calcium currents in the thalamus. So because it's in the thalamus, this should hopefully help us remember that the calcium currents they block are T-type. So, okay, they block the T-type calcium currents in the thalamic neurons. The side effects, the one that is quite typical for ethosuximide is headache, and they can also cause GI complaints like nausea, vomiting, and anorexia. They can also cause behavioral changes, specifically euphoria or an abnormal feeling of a very, very elated mood. So those are your ion channel inhibitors. Let's move on to the drugs that enhance GABA synaptic transmission. So they are quite easy to remember because they have GABA in their name. So gabapentin, pregabalin, diagabin, and vigabatrin. So these are all drugs that enhance the transmission of GABA, which is our main inhibitory neurotransmitter in the central nervous system. So your gabapentin and your pregabalin, they block the calcium alpha-2 delta channels. Again, they block the calcium alpha-2 delta channel. So natanong na siya dati which particular calcium channels they block. It's your alpha-2 delta channels. So by blocking these calcium alpha-2 delta channels, we cause decreased glutamate release, and we also inhibit neuronal discharge from seizure foci. We can use these drugs in focal seizures, And they are also the first-line treatment for neuropathic pain, particularly in your post-herpetic neuralgia. So what is post-herpetic neuralgia? It is the feeling of persistent pain, burning, tingling sensation in patients who have suffered from shingles. And this can be very, very debilitating. So gabapentin and pregabalin are your first-line treatments. The side effects include dizziness and sedation, and something to note is that they also have the same effects on your calcium currents like your ethosuximide. And your pregabalin is also manufactured as a combination drug with methylcobalamin for neuropathic pain. So I don't think this last point will come out in the boards. It's just something that's good to know. So if gabapentin and pregabalin block the calcium channels directly, your tiagabid and your vigabatrin naman inhibit reuptake and metabolism of GABA respectively. So if we look at the figure on the left, we can see that tiagabine blocks your GAT1, which is the channel responsible for the reuptake of GABA. So parang similar to your SSRIs, remember your serotonin, your selective serotonin reuptake inhibitors. By inhibiting the reuptake channel, we increase the amount of time that GABA spends in the synapse and therefore increasing its duration of effect. So we use this as an adjunct for refractory focal seizures. And unfortunately, we have to make sure that the patients we give it to have epilepsy because in those who are given tiagabine, and if their seizure is only reactive and actually not epileptogenic, it can trigger further seizures. Vigabatrin naman, so if we look at the figure on the left, we can see that GABA is degraded into succinic semialdehyde via the enzyme GABA-T or GABA transaminase. So this is the enzyme that deactivates your GABA. So vigabatrin works to inhibit this. So you can see in the name GABA-T, so it inhibits GABA transaminase. So again, it is also used as an adjunct for refractory focal seizures, and it is not first line. It is only an adjunct because it carries a black box warning of permanent bilateral vision loss. Okay, vigabatrin presents with a black box warning of permanent bilateral vision loss. Lastly, we have your levetiracetam or your brivaracetam. Mas common ang levetiracetam. It selectively binds to your SV2A or your synaptic vesicular protein. So we can see in the picture here, this is what SV2A does. It is a protein that allows the vesicle to combine with the cellular membrane of the neuron, allowing the contents of the synapse or the vesicles to be released into the synaptic space. So this inhibits hypersynchronization of neurons in epileptiform firing. It modifies synaptic release of both glutamate and GABA, and it also inhibits your calcium channels. It is broad spectrum, meaning it can be used in both focal and in generalized tonic-clonic seizures, but it does have side effects of ataxia, dizziness, hallucinations, and psychosis. So unlike most of your anti-epileptic drugs, which are inducers, or your sodium valproate, which is an inhibitor, the levetiracetam is neither an inhibitor nor an inducer of your CYP450. So it has very minimal drug interactions. Okay. So just to quickly give you an overview of the drug of choice for seizures. So the reference here is your Harrison's. When it comes to your generalized tonic-clonic seizures or your grand mal seizures, as they used to be called, we prefer lamotrigine or valproic acid. If it is a female of reproductive age, we prefer lamotrigine due to valproic acid's highly teratogenic effects. If it's a focal seizures, you have quite a few choices as long as they're broad spectrum. If they're absence, I would recommend you pick ethosuximide in the boards, but you can also use valproic acid and lamotrigine. And if they are myoclonic or atypical absence seizures, you can use valproic acid, lamotrigine, or topiramate. So if you can see, it looks like lamotrigine is the safest answer out of all four. So if you're not sure, pick lamotrigine. So let's do a section synthesis to make sure that we remember all of the drugs mentioned earlier. So in terms of your anti-epileptic drugs, which one do we use for trigeminal neuralgia? Remember that we use your carbamazepine. Okay. What about your acute mania and bipolar disorder? We can use your VLC, your valproic acid, lamotrigine, and your carbamazepine. For your hyperbilirubinemia, what do we use? We use your barbiturates or your phenobarbital. Remember, because it is a very potent inducer of your hepatic enzymes. For your post-herpetic neuralgia, we can use gabapentin or pregabalin, which are the drugs of choice. Lastly, let's another section synthesis in terms of the teratogenic effects. Which one causes fetal hydantoin syndrome? So from the name hydantoin, we know it's phenytoin. The drug that causes both spina bifida and craniofacial anomalies is your carbamazepine. The drug that is known to cause spina bifida alone is your valproic acid. In terms of the most common side effects, your hydantoins and your carbamazepine, they will present with diplopia ataxia. Your valproic acid, ang most common ay ang GI upset. And your barbiturates, the most common side effect is your sedation. Must know side effects, which of the drugs or your anti-epileptic drugs cause gingival hyperplasia? That is your phenytoin. Which of the drug is most implicated in Stevens-Johnson syndrome? It's your carbamazepine. And which can we not give in acute intermittent porphyria because it can trigger further episodes? It is your barbiturates. Again, because they induce the enzymes responsible for heme synthesis. Therefore, you cause an increase in the buildup of heme substrates, which are what cause the toxic effects of acute intermittent porphyria. CYP450, phenytoin, carbamazepine, and phenobarbital, are they inducers or inhibitors? Again, almost all of them are inducers, and si valproic acid lang ang inhibitor. So which of the anti-epileptic drugs, again, is relatively neutral, neither an inducer nor an inhibitor? It's your levetiracetam, which acts on your SV2A or synaptic vesicular protein. So that's it for your anti-epileptic drugs. Siguro the answers here, yun na yung mga pinakakailangan yung alamin. Next, let's talk about your anesthetics. So when we talk about general anesthesia, it is a neurophysiologic state characterized by all of these features. So depending on the reference, some will say the triad of GA is analgesia, meaning you cannot feel pain, hypnosis or tulog, and your muscle relaxation. Though sometimes some people will replace hypnosis with amnesia, making sure you don't remember the events that happened during the surgery. So unconsciousness, analgesia, amnesia, muscle relaxation, and loss of reflexes are very important in somebody undergoing major surgery. We want to make sure they are not conscious of what's being done to them. We want to make sure they don't feel pain, that they cannot remember the events of the surgery, that they are relaxed so that the surgeons can operate safely, and that we inhibit their reflexes, their cough reflex, their knee-jerk reflexes, etc. Because we have to make sure that the body is not moving whilst we are performing surgery. So there are several agents that we use for general anesthesia, and they serve to produce different parts of the general anesthesia. So for example, your hypnosis, we have your sedative hypnotic drugs like your propofol and your ketamine. For amnesia, we tend to give benzodiazepines. Remember, benzos produce anterograde amnesia or amnesia after the giving of the drug. So if we induce somebody for anesthesia and we give benzos, it is with the hope na hindi nila maaalala yung surgery after the induction. Analgesia or pain, or of course, we give your opioids like your fentanyl, your morphine, and your oxycodone. And for the paralysis, we give your neuromuscular blocks. So these are drugs that block the neuromuscular junction, so they can be either depolarizing like your succinylcholine or non-depolarizing like your curares, your atra, and your rocuronium. So let's start by talking about your inhalational anesthetics. So they facilitate GABA inhibition, therefore they are CNS depressants. They block NMDA, so they block glutamate, and they block your acetylcholine receptors in the brain. So what are their physiologic effects? So they can have hemodynamic effects, which are the most prominent. So they cause decreased systemic blood pressure because of their vasodilation and myocardial depression, which is why any patient who undergoes general anesthesia first has to have pre-op clearance, meaning we have to make sure that they are able to tolerate this decreased blood pressure. And second, they require continuous monitoring whilst intraoperatively. They also have respiratory effects, so they eliminate the ventilatory drive, and patients who undergo general anesthesia are unable to protect their airway because they no longer have protective airway reflexes like your gag or your cough reflex, which is why patients who receive inhalational anesthetics must be intubated in order to protect their airways, and which is also why we make sure that patients who are about to undergo anesthesia have adequately fasted because we don't want the contents of their stomach to be regurgitated and eventually aspirated by the patient because wala silang protective airway reflexes. Now, the potency of your inhalational anesthetics is determined by what we call the MAC, or the minimum alveolar anesthetic concentration. So at 1 MAC, so a MAC of 1, this is the partial pressure of inhaled anesthetic in the alveoli, wherein 50% of the population become immobile at surgical incision. So if you have a MAC that is lower, the potency is higher because we need less of the inhaled anesthetic to produce immobility at surgical incision in 50% of the population. So the drug with the lowest MAC, meaning it is the most potent drug, is your methoxyflurane. And the drug with the highest MAC, meaning it is the least potent, is your nitrous oxide or your laughing gas, which if we have watched sitcoms from the States, we typically see these in dental procedures, diba? So your inhalational anesthetics, they all have quite special side effects that will help you remember which is which. So see desflurane, okay, so this drug has a very pungent odor, and what you have to remember is it can cause bronchospasm. So because it has the ability to cause bronchospasm, it is contraindicated in your asthmatic patients. See sevoflurane, the way I remember it is sevo, sabon. So it's soap, it is sweet smelling, and it causes bronchodilation. So it is actually the best for asthmatics in comparison to your desflurane, which is contraindicated in your asthmatics. Your isoflurane can cause what we call the coronary steal syndrome. So essentially, in a coronary steal syndrome, what happens is in patients who have coronary stenosis, vessels are dilated at baseline. So they are dilated as much as possible in order to allow as much blood flow. Now, if we give isoflurane, which is a potent vasodilator, ang nangyayari, the other vessels of your coronary system become also very maximally dilated. So the blood flow, instead of going here through the stenosed vessel, gets shunted towards other dilated blood vessels. Therefore, you get ischemia. In the myocardium perfused by stenosed vessels kasi ninakaw siya ng other vessels, okay, which are now maximally vasodilated because of your isoflurane. So again, desflurane, pungent odor and bronchospasm; sevoflurane, sabon, sweet smelling and bronchodilation; isoflurane, coronary steal syndrome. And flurane is also has a pungent odor. It can cause a spike and wave pattern on your EEG and can cause breath holding in some patients. See, halothane, it wreaks havoc on your hepatic system and therefore can cause halothane hepatitis, so HH, halothane hepatitis. Methoxyflurane, like I said, has the highest potency, and this also means it has a very, very slow recovery. So anesthesiologists are not just concerned about putting patients into general anesthesia, they are also very concerned about making sure the patients wake up from general anesthesia. So although this is very good at putting patients to sleep, it can also cause a lot of worry because recovery from anesthesia is also longer as compared to with your other anesthetics. Your nitrous oxide, like I said, is the lowest potent, and it also is the least cardiotoxic, so it has the least cardiovascular depressing effects, and it is the only inhaled anesthetic that causes increased intracranial pressure, whereas the rest would cause decreased ICP. Now, what is something really important to watch out for in patients who are about to receive inhalational anesthetics? This is what we call your malignant hyperthermia. I touched on this briefly sa serotonin syndrome and neuroleptic malignant syndrome, but I'll discuss it again here. So malignant hyperthermia is caused by a genetic defect in your ryanodine receptors or your IYR1 expression. So essentially, anesthesia causes or triggers your ryanodine receptors to open and cause a massive efflux of calcium into your muscle cells. Okay, so what happens when you have a lot of available calcium? The muscles contract, and through the muscle contraction, you are able to generate heat. So these patients become very, very rapidly hyperthermic. In addition to the heat, the muscles become extremely rigid, and this can cause skeletal muscle death and breakdown, releasing myoglobin into the system. This myoglobin gets stuck in the kidneys, causing rhabdomyolysis, eventually leading into multi-organ damage or failure. So again, malignant hyperthermia is caused or triggered by inhalational anesthesia. So in addition to inhalational anesthesia, we also have IV anesthetics. So your IV anesthetics, as in the name, are given intravenously, and they have different functions and different side effects as well. So your ketamine functions via antagonizing your NMDA receptor, which is an important receptor in the transmission of glutamate. So what it causes is dissociative anesthesia. So what is dissociative anesthesia? It is catatonia with retained consciousness. So parang nagka-outer body experience where the physicality of the person is catatonic, so they look as if they're completely out of it, but they have retained consciousness. So ketamine is one of the IV anesthetics that causes increased ICP, and it causes emergency delirium, which is what happens in this case is after the ketamine wears off, the patients will report delirium. So when they emerge from the anesthesia, they become delirious. And it causes CVS stimulation instead of the depression that we normally see in other anesthetics. Etomidate works by modulating your GABA-A receptor, and it also causes minimal cardiorespiratory depression, which is why we prefer it in patients in the ICU. So kung kailangan i-sedate yung mga ICU patients, we give etomidate kasi it doesn't cause depression of their cardiac and respiratory symptoms. However, what it does suppress is your adrenocortical function. So they can have adrenal insufficiency, which is something we have to watch out for in ITU patients. We can, of course, give IV opioids, which will produce analgesia. And if we give too much, the antidote for opioid toxicity is your naloxone. And we can give propofol, also called your milk of amnesia. So it looks like a white milky substance. What it does is it potentiates GABA, the inhibitory neurotransmitter, and it also blocks sodium. It is the IV induction agent of choice. However, one of its side effects is your propofol infusion syndrome. So what is propofol infusion syndrome, or PRIS? It is a syndrome characterized by severe metabolic acidosis, arrhythmias, acute renal failure, rhabdomyolysis, and cardiovascular collapse. So there is unfortunately no antidote for PRIS. The best we can do is give the patient supportive therapy and stop the propofol infusion. Next, let's talk about local anesthetics. So local anesthesia just refers to a loss of sensation in a very limited region of the body. So of course, if we want to, for example, undergo a Thule mission, or we want to do a simple suturing of a cut, we would just give a local anesthetic instead of making the patient undergo general anesthesia, because this has far fewer side effects, especially when done properly. Now, there are two types of local anesthetics, your esters versus your amides. So the way to remember their names is by the mnemonic one-eyed Easter bunny. So your esters have only one I in their name. So tetracaine, procaine, benzocaine, isa lang yung I. Now, one of these is the longest acting, and that is your procaine, kasi a pro finishes the race fast. Sorry, not longest acting, shortest acting. Okay, so procaine is the shortest acting local anesthetic, kasi a pro finishes the race fast. Amides have two I's in their name, so bupivacaine, ropivacaine, and lidocaine. Dalawa yung I. And that will let you know it is an amide local anesthetic. And the way to remember which one is the longest acting local anesthetic is to remember that you are at the end of a long rope. So ropivacaine is the longest acting local anesthetic. So how do local anesthetics work? So essentially, most of your local anesthetics are weak bases. So they enter the cell. So La is for local anesthetic and H is your hydrogen ion. So they enter the cell in their unionized form as La. And then when they enter the cell, they become trapped in their ionized form, so LAH+. And because they are now ionized, they can no longer exit your neuron cell. So they stay inside the neuron and they are able to exhibit their sodium blocking effects. So they enter the sodium channel and they block the sodium channel. Now compare it to, this is why your local anesthetics are not that effective in an acidic environment. So for example, meron kang abscess or meron kang highly infected area na gusto mo i-anesthetize. That is because in a highly infected area, you have a lot of hydrogen ions available to therefore ionize your local anesthetic. And ionized molecules cannot enter the cell membrane as easily as unionized molecules, which is why we cannot really give local anesthetics that effectively in abscesses and highly infected tissue. Now, what is last? Last is local anesthetic systemic toxicity. Remember, whenever we give local anesthetic, bago natin i-push yung injection, we try to aspirate first and make sure we're not in a blood vessel. Because if we inject it into a blood vessel instead of in the tissue which we want to anesthetize, we can develop last. So what are the symptoms of last? They have both central nervous systems and cardiovascular system effects. So they initially will actually present with excitation of both your CNS and your CVS. So the most common or perhaps the most buzzword effects you need to know are circumoral numbness and tongue paresthesias. So if you give a patient lidocaine, for example, kasi may tuli mission or whatever, and they start to complain of numbness and paresthesia around their tongue and their mouth, be very cautious that could be the early symptoms of last. And when it starts excitatory, it eventually goes into CNS and CVS depression, which is typically the cause of death in patients with last. This is when you get respiratory arrest, hypotension, bradycardia, and in the worst cases, asystole. What is the antidote for LAST? We give an intralipid IV infusion. So this IV infusion sort of picks up the local anesthetic in the vessels and prevents it from exerting their effects. So ito yung mga special na local anesthetics that you guys need to know. Again, si Procaine, siya ang may shortest half-life. Si benzocaine can cause methemoglobinemia, and this is a local anesthetic that is applied topically or on the skin. And it is very important that we use it with caution on damaged skin because it can cause methemoglobinemia. Cocaine is the only local anesthetic that is a vasoconstrictor. So yes, cocaine is a local anesthetic. It is preferred in surgeries of the head and the neck because it prevents bleeding during these surgeries kasi it is a vasoconstrictor. As for your amide local anesthetics, lidocaine is also an antiarrhythmic, specific to your group 1B antiarrhythmics. They are preferably used post-MI and in digitalis toxicity. Prilocaine, as well as your benzocaine, can cause methemoglobinemia. Bupivacaine is the most cardiotoxic out of all of your local anesthetics. And ropivacaine, again, has the longest half-life. So it is the enantiomer of your bupivacaine. However, it is less cardiotoxic. So let's answer a few questions on your anesthetics. During local infiltration anesthesia, using lidocaine, what mechanism of action is seen? So again, how do local anesthetics work? Remember, they block your voltage-gated sodium channels, thereby preventing neural transmission and preventing the perception of pain. Which of the following local anesthetics is a useful antiarrhythmic agent? Is it cocaine, bupivacaine, lidocaine, or ropivacaine? Remember, it is your lidocaine. In particular, it is a group 1B antiarrhythmic, very helpful in the use of post-MI arrhythmias and in digitalis toxicity. Let's answer a few summary questions. So which of the inhalational anesthetics is known to cause hepatitis? Remember, halothane causes wreaks havoc on your hepatic system. Halothane hepatitis. Inhalation anesthetic that is sweet-smelling, so sabon, sevoflurane. Pungent odor and also causes bronchospasm, therefore contraindicated in asthmatics, is your desflurane. Coronary steal syndrome, so causing myocardial ischemia at the point after in an area of coronary stenosis, this is your isoflurane. And your inhalational anesthetic with the highest potency or the lowest MAC, that is your methoxyflurane. IV anesthetic that increases your intracranial pressure, that's your ketamine. Drug of choice for induction is your propofol or your milk of anesthesia or amnesia. Your antidote for benzodiazepine toxicity is your flumazenil, and your antidote for opioid toxicity is your naloxone. The only vasoconstricting local anesthetic is your cocaine. The most cardiotoxic is your bupivacaine. Associated with methemoglobinemia and applied topically is your benzocaine. And the antiarrhythmic class of lidocaine is class 1B. Next, let's talk about your smooth muscle relaxants, which are also used in general anesthesia. So the smooth muscle relaxants are your neuromuscular junction blocking agents. So recent board questions have included NMJ blockers and anesthetics in their questions. So let's not forget to study these drugs also. So we have two main types of your NMJ blockers. They can be either depolarizing or non-depolarizing. So under depolarizing drugs, we have your succinylcholine, siya lang yung nag-iisa. And your non-depolarizing drugs usually are your curares. So they have the cure in their name. Tubocurarine, atracurium, vecuronium, rocuronium. So Doc, paano naging muscle relaxant si succinylcholine if its mechanism of action is depolarization? Hindi ba, Doc, magkakos ng muscle contraction kapag nag-depolarize? So it's actually the persistent depolarization at the neuromuscular junction end plate that causes paralysis. Kumbaga, parang napagod yung muscle sa kaka-stimulate at sa kaka-depolarize, kaya naging insensitive siya to further stimulation via acetylcholine, which is usually what the neuromuscular junction uses to cause muscle contraction. Yung non-depolarizing naman, it just antagonizes your acetylcholine receptors. Therefore, kung na-antagonize yung acetylcholine receptors, walang muscle movement or muscle contraction. Another important thing to know about depolarizing blockers like your succinylcholine is meron siyang dalawang phases of blockade. Phase 1 is persistent depolarization. So what happens is because the membrane becomes depolarized, nagiging unresponsive siya to subsequent impulses. So this results in flaccid paralysis. In phase 2 naman, the membrane does repolarize, however, desensitized na siya to further stimulation. Pagod na siya. So the mechanism is still unknown as to why phase 2 still results in muscle relaxation, but they do believe that the channels behave as if prolonged closed state na sila. So therefore, there is no muscle contraction even with further stimulation. Another important difference is in phase 1 blockade, wala tayong antidote, okay? So in phase 2 we can typically give cholinesterase inhibitors like your neostigmine as an antidote. However, in phase 1, if we give neostigmine, we actually potentiate the muscle blockade caused by your succinylcholine. In addition, when we do a train of 4 stimulation, so ano yung train of 4 stimulation? It's when you stimulate a muscle 4 times and you check how well the muscle twitches in response. Sa phase 1, meron kang constant but diminished response. So ito yung normal train of 4. So stimulate, the muscle twitches accordingly. Sa phase 1, may twitch pero diminished. Sa phase 2, meron tayong fade. Pagod na yung muscle. This is quite similar to the non-depolarizing blockers, which also exhibits a fade pattern in the train of 4 stimulation. So, Doc, why would we even give cholinesterase inhibitors if we were to try to reverse the neuromuscular blockade caused by these muscle relaxants? So remember, when it comes to a muscle contraction at the neuromuscular junction, we release acetylcholine. This is received by the acetylcholine receptors, and this causes a muscle contraction. So we want to give cholinesterase inhibitors to inhibit the degradation of acetylcholine. So tumataas yung acetylcholine concentration in the neuromuscular junction. So let's look at some key differences between your depolarizing and non-depolarizing drugs. Again, ang prototype natin sa depolarizing si succinylcholine. Sa non-depolarizing, yung mga curares natin. Mechanism of action, agonist, si depolarizing, and competitive antagonist, si non-depolarizing. Yung side effects are also very different. Si depolarizing will cause malignant hyperthermia, hyperkalemia, muscle pain, and damage because you keep on contracting those muscles. Versus a non-depolarizing where you get respiratory paralysis and apnea, which is potentiated when we give our aminoglycoside antibiotics. For the reversal agents, paralysis can be worsened when you give neostigmine, which is a cholinesterase inhibitor. So non-depolarizing, we can give neostigmine. So bakit tayo nagbibigay ng cholinesterase inhibitors in neuromuscular junction blocking? If gusto nating i-reverse yung skeletal muscle relaxation, that's because we want to increase the levels of acetylcholine. So cholinesterase, remember, from cholinesterase, it degrades your acetylcholine. So kung gusto nating taasan yung acetylcholine para magkaroon na tayo ng muscle movement in the presence of your neuromuscular junction blockers, we give a cholinesterase inhibitor. Si rocuronium naman, meron siyang special reversal agent as that is your sugamadex. For notes, atracurium, which is one of your intermediate-acting non-depolarizing neuromuscular junction blockers, it undergoes what we call Hoffman elimination, and it yields laudanosine, and this is what causes seizures in patients who receive atracurium. So si succinylcholine, if we have a trauma patient, kunwari meron siyang burn or crush injuries, we do not use succinylcholine as a neuromuscular junction blocker. Bakit? Because of its effect as a depolarizing agent, it does cause potassium leaks. So remember, potassium is mostly an intracellular ion. So it causes a potassium leak. And in patients who already have tissue damage and burns, meron ng cell lysis, releasing a lot of potassium into your bloodstream, you can potentiate the hyperkalemia, leading to, of course, the side effects of potentially fatal arrhythmias. We also have your central and peripheral spasmolytics, which I discussed previously. But just as a review, remember your baclofen acts on your GABA B receptors, the GPCR GABA B receptors, and they are agonists at those receptors. And your tizanidine is an alpha 2 agonist at the spinal cord. So both of these drugs act to inhibit glutamate release, kasi glutamate release causes positive action potentials. So if you block glutamate release, you get muscle relaxation. Peripherally naman, we have dantrolene, which is a calcium channel blocker to block ryanodine calcium release. So ano nga yung alam natin na cause of deficient or not deficient, but excessive calcium release from your ryanodine receptors? It is your malignant hyperthermia. Kaya dantrolene yung binibigay natin na antidote. Okay, second to the last topic in central nervous system drugs are your opioid analgesics and your antagonists. So we have agonists, mixed agonist antagonists, and we have pure antagonists. So ano nga ba yung opioids? Essentially, anything produced by the body that acts through an opioid receptor is an endogenous opioid. So meaning we produce it ourselves. There are three most distinct families of opioids. They are your enkephalins, endorphins, and your dynorphins. Your endorphins act on the mu opioid receptors. Your enkephalins act on your delta opioid receptors. And your dynorphins act on your kappa opioid receptors. So mu, delta, kappa. When these opioid receptors are activated, they reduce opening of calcium channels. And diba, one of the steps in neurotransmitter release before the vesicles release their contents is an influx of calcium. So by reducing the opening of calcium channels, we reduce neurotransmitter release. We also stimulate potassium current, thereby hyperpolarizing a cell and therefore also reducing action potentials. So here are the spinal sites of action of your opioids. So the mu, the delta, and the kappa agonists reduce excitatory transmitter release from presynaptic terminals of nociceptive or pain-receiving afferent nerves. So again, they inhibit calcium influx, therefore inhibiting transmitter release, and they also increase potassium conductance by increasing potassium efflux. The mu opioid agonists also hyperpolarize second-order pain transmission neurons by increasing potassium efflux then, therefore evoking an inhibitory postsynaptic potential. So ang sinasabi lang nito is they all work to reduce the feeling of pain by inhibiting neurotransmitter release. Okay? So your mu1 and your mu2 receptors, they are very important with analgesia. They can cause, especially your mu2 receptors, they can cause physical dependence, meaning patients feel physical symptoms when they are dependent on the opioid drug and you remove the opioid drug from their system. They will have severe flu-like symptoms, vomiting, shivering, sweating, and also they can cause very marked constipation. So again, yung antagonists at these receptors are your naloxone and your naltrexone. So all of these will produce analgesia, okay? So all of these opioid receptors. Now, maraming side effects ang opioids, but the side effects which display minimal or no tolerance, what does that mean? Even if sanay na yung tao maka-take ng opioids, these side effects will still predominate. And these are your meiosis, your constipation, and your convulsions. So meiosis and constipation, yung dalawang pinaka-important na ialala nyo. So an overdose of opioids will have a very classic triad of pupillary constriction or pinpoint pupils, comatose state, and respiratory depression. So what are full agonists at your opioid receptors? We have your morphine, hydromorphone, and heroin. These are strong mu receptor agonists. We have your fentanyls, which are much more potent than morphine and can be given transdermally. So here in the UK, we sometimes give fentanyl patches to patients with very chronic pain. We can give meperidine, which is used in post-operative shivering via alpha-2 antagonism, similar to your tizanidine. And one thing to note about meperidine is it causes mydriasis, so widening of the pupil instead of your pinpoint pupils. Methadone is also a strong agonist at the mu receptor, and it is used in opioid dependence. So this will help people wean themselves from opioids without feeling such terrible detox side effects like your shivering, flu-like symptoms, vomiting, etc. However, some patients can also get addicted to methadone, so it is a tricky balance. We also have partial agonists. So what are partial agonists? They are ligands that bind specifically to the opioid receptors, but they have limited intrinsic activity. So for example, kung si fentanyl will produce 100% of the intrinsic activity, ito sila, they may produce 50% or less. So examples of these are your hydrocodone, oxycodone, and dihydrocodeine. So they are strong mu and kappa receptor agonists, but they antagonize also glutamate. So hindi sila 100% agonist because they have limited intrinsic activity. Si dextromethorphan, which is the main component found in your cough syrup, and si codeine, they decrease sensitivity of your cough receptors by depressing your medullary cough, which is why dextromethorphan is used in cough syrup. And they also have an added effect of NMDA antagonism, which is thought to be the mechanism that explains hallucinations in dextromethorphan or cough syrup. So this also came out in the recent boards. Ano do yung cause of hallucinations in dextromethorphan overdose? It is thought to be due to NMDA antagonism. Next, we have your mixed agonists and antagonists. So why do we have mixed agonists and antagonists? So essentially, they can have ceiling effects. So unlike with morphine, where if you keep on giving them, you just increase and increase your respiratory depression. If you give, for example, nalbuphine at doses beyond 30 milligrams, for example, it no longer depresses respiration as much as regular morphine does because of its antagonistic effect. So mixed agonist-antagonists will have partial mu receptor agonist effects, so they can still produce analgesia, but they can be antagonists at your kappa and delta receptors as well, thereby decreasing the risks of respiratory depression. So there are different uses for mixed agonists and antagonists. So for your butorphanol is used in post-operative shivering. Buprenorphine is used in opioid withdrawal states, and your nalbuphine and pentazocine is an agonist at kappa, but an antagonist at mu, which is different from the above two mixed agents that I mentioned. We also have opioid antagonists, which competitively block your mu, delta, and your kappa receptors. So this is very useful in opioid overdose, specifically your naloxone. So whenever a patient presents with pinpoint pupils, respiratory depression, and comatose state, we know that it is most likely an opioid overdose. We have to give naloxone. Naltrexone is useful in opioid and alcohol dependence. It reduces the cravings in alcohol as well, as I mentioned in the alcohol chapter. So let's do a few practice questions. Which of the following is given for morphine addiction? It is usually started when the morphine withdrawal symptoms have started. So the answer here is your buprenorphine. So I mentioned it is used in opioid withdrawal states. Next, we'll talk about your drugs of abuse. So when we talk about drugs of abuse, typically patients will have both dependence and tolerance on these drugs. Therefore, they keep on increasing their consumption of these recreational drugs. So what is dependence? It is the need to constantly take the drug due to signs and symptoms experienced when the drug use is withdrawn. So these are your withdrawal symptoms. Whereas tolerance is a decreased response to drugs. So diba, high tol, low tol, it means you need more and more of the drug or the alcohol in order to produce the same effects. So we can typically divide them into stimulants and your hallucinogens. So your stimulants, as the name suggests, they usually stimulate your sympathetic system. So we have meth or shabu. What it does is it promotes release of your norepinephrine, a catecholamine, dopamine, and serotonin. So patients will typically be very agitated. They can have psychotic states with delusions and a lot of paranoia. They can be hyperthermic and they can go into sympathetic overdrive. It is thought that acidification of urine can promote elimination of this drug. So sometimes patients who want to avoid showing meth in their drug test will try to acidify their urine so that they can eliminate the drug from their system quicker. So MDMA is a selective serotonin releaser. So MDMA or ecstasy can cause massive dumps of serotonin in the brain. So it can present with hypertension, delusions, hallucinations, hyperthermia as well, and serotonin syndrome. Cocaine or coke, as we know, is a local anesthetic, but it is also used as a recreational drug. What it does is it inhibits reuptake of dopamine, norepinephrine, and serotonin. So these neurotransmitters stay in your synapses longer. So they do have meth-like effects, but are much more short-lasting. So the key features are enhanced self-confidence and sympathetic overdrive. Now, if you remember, cocaine is a potent vasoconstrictor, so it can cause a myocardial infarction because of the vasoconstriction of your coronary vessels and arrhythmias, as well as bowel ischemia kasi yung vessels that provide blood to the bowels are maximally vasoconstricted. We also have hallucinogens, so PCP and ketamine. What they do is they antagonize the glutamate NMDA receptor. Ano pa yung isang nag-antagonize ng glutamate NMDA receptor? Di ba your dextromethorphan, the thing found in your cough syrup, which is why cough syrup can also be hallucinogenic when taken in massive doses. PCP is thought to be the most dangerous hallucinogen, and the key features include things like psychotic reactions, reckless behavior, nystagmus, which is quite like a characteristic finding in PCP, and in ketamine, like I said, the dissociative amnesia, okay? LSD and psilocybin, or your psilocybin, are also known as your mushrooms. What they do is they have a very potent hallucinogenic effect, so they create very, very vivid visual hallucinations. And your marijuana, so the THC is the active hallucinogenic component, whereas the CBD is commonly used in the medical management of pain and anxiety. So typically, these patients will present with disinhibition, dry mouth or your cotton mouth, and reddened conjunctiva.